Good morning, everyone, and welcome. So happy that you all are here. Welcome to the Lung Cancer Screening Implementation Forum, How to Create a Successful and Effective Lung Cancer Screening Program at Your Healthcare Facility. I'm Flora Pastorero, and I worked in television news for many, many, many years. I'm not going to tell you how many because you're going to go, she's that old. I now work with a website called penwatch.org, and we call it penwatch.org because we're watching Pennsylvania. And what I like about this website is it's giving me the opportunity to spread great news about wonderful things that are happening in this state, including all the wonderful work that the American Lung Association is doing, not just here in Pennsylvania, but across the country. And I think we do need to raise awareness and get the message out about what is going on. I'm happy to be here for a number of reasons. Specifically, I have a personal connection to this, and I just get emotional even thinking about this. When my son was very young, he had asthma, and the first time he had an asthma attack, I didn't know what was happening. I didn't have any kids and had no knowledge of asthma and what is happening. And when you see your child gasping for air and not being able to breathe, it is so terrifying, terrifying. And how many times we had to rush him to the hospital. And it's true. It's like watching a fish out of water. And it makes you understand and realize how important our lungs are. How important our lungs are and how we have to love our lungs and take care of our lungs. Because at the end of the day, if you can't breathe, nothing else matters. So I am happy to be here today to not only share that story, but to share the message of the American Lung Association and to raise awareness about lung cancer, the #1 cancer killer of women and men in this country. So again, thank you for being here. To all of you here in the room, thank you. And for those who are watching us live stream online, thank you for watching. We also want to thank the staff today who worked to organize the event. Thank you to the Pennsylvania Department of Health, the Bureau of Health Promotion and Risk Reduction for making everything possible. Now, at registration, you should have received a copy of the Lung Cancer Screening Implementation Guide. This was created with the assistance of the American Thoracic Society. If you don't have one, you can find me, and I'll make sure you get that, or I'll connect you with a lung cancer staff member, and we'll make sure you get that. We are going to have lunch served buffet style from 12:30 to 1:30. Also, very important, the restrooms are out the door and to the left, right down there to the hallway. Today, you're going to hear from the American Lung Association Chief Mission Officer Deb Brown on the vast resources of the Lung Association, its program's mission, lung force, and so much more. She's also going to talk about insurance reimbursement for lung cancer screening. Dr. Albert Rizzo is the Chief Medical Officer for the American Lung Association. He is here as well. He's going to go over the screening implementation guide as well as Save by the Scan. We're also going to hear from Dr. Troy Moritz of UPMC Pinnacle. He will present his case study on lung cancer screening. We're also going to have a question and answer panel following our guest speakers today, Dr. Lauren Robinson from the Pennsylvania Department of Health. So to kick things off today, it is my pleasure and honor to introduce Dr. Rizzo. Dr. Rizzo.
Good, okay. Well, thank you for all being here this morning. If you don't mind, I'm going to stay down here rather than the podium. A couple reasons. Make it more interactive. Also, I can see the slides better if I move closer to here. So I'm going to follow a script that was put together by Eva. I'm actually a native of Pennsylvania. I grew up in Williamsport, Pennsylvania. Spent all my young years there. And practice now down in Wilmington, Delaware. So not too far. A little bit of a train ride from Philadelphia this morning. My time with the American Lung Association has been a long volunteer tenure of about probably 25 to 30 years, and more recently I've been able to act as the Chief Medical Officer for about the past 6 to 7 months. So It really makes me feel like I'm doing a lot more for my patients that I see every 20 minutes in the office, when I can help legislate or advocate for a law, when I can help spread education about lung cancer screening, about care for asthma. So I think this is just an extension of my practice, and I appreciate the opportunity to do this. Lung cancer screening actually has been around for a while. Now, when I say that, up until about 2010, 2011, going back into the 80s and 90s, people tried to screen for lung cancer with chest x-rays. They tried to screen by collecting sputum from patients who were coughing up mucus. And they were done at Johns Hopkins and Mayo Clinic. There were a lot of good studies that were done to try to show that we could find lung cancer early and make a difference. But what those studies did show is we could find the lung cancer, but was never finding them early enough using things like chest x-rays and sputum tests. And therefore, it wasn't really impacting the patients' lives. They were getting diagnosed with the cancer probably earlier than they otherwise would, but the treatment wasn't able to be intervened upon in a way that made a difference. Finally, the national study, NSLT, National Lung Cancer Screening done by NIH, released its report in 2011 and showed at that time if they did low-dose CT scans compared to chest x-rays in a group of individuals who were considered high risk, and I'll mention what those criteria were in a minute. They showed that by following those patients with yearly scans over about 3 years and following them out 8 years later, they showed a mortality improvement of about 20% in that population. And that was the first study to really show that we could make a difference by finding cancer early. And I'm sure, as you'll hear from Dr. Moritz and the other doctors today, finding cancer early often means surgery, getting it taken out, and curing it. Not always, but it is more easy to cure if you find a cancer early in lung disease. Lung cancer is notorious for being a very silent process in the lung. By the time it leads to symptoms like cough, spitting up blood, chest pain, it's often an advanced stage at that point. And the outcomes are much less favorable. Stage 1, which we'll talk about later on, if you find it in stage 1, your cure rate after 5 years can be up in the 54% or higher range. If you look at all lung cancers, 5-year survival for all comers is usually less than 15%, sometimes as low as 5%. So we want to find it early. Can we go back to the last slide? I'm sorry. I'm talking too long on each slide. She's moving me along here. Okay. So in 2012, a number of organizations, including the American Lung Association, the Cancer Society, Thoracic Society, we all came up with guidelines based on that study. The 50,000 patients that went through the NSLT showed improvement and mortality benefit. So we put out guidelines saying patients who are at high risk should talk to their doctors about getting screened for lung cancer with a low-dose CAT scan. What we needed to do to make that more available to patients is we needed to have insurance companies pay for it. So in 2013, the United States Preventive Services Task Force looked at all the data about lung cancer screening and made a recommendation, grade B. And not to get into specifics, but according to the Affordable Care Act, if the USPSTF would say something was recommended A or B level, insurance companies had to pay for it with no additional cost to patients. So that was important that by January of 2015, commercial insurance needed to pay for lung cancer screening in that population who was felt to be at risk. Shortly thereafter, a number of the organizations, including the Lung Association, lobbied Medicare to come up with the same agreement that they would pay for screening in that population. Now, that carried a few other issues along with it that make it a little bit of a struggle, and we'll talk more about that. But over the last few years, more and more patients are being asked to get screened if they're at high risk. Trouble is, it's still a very low number of patients who should be screened who are actually getting screened, and we'll talk about that. And that's why it's important to be in a situation where you're thinking about or you already started a lung cancer screening program in your institution, because the more physicians know about it and have access to these programs, the more patients who are appropriately needing the screen will get screened. In order to help move this along, we had an Ad Council and Lung Association study back in August of 2017. We launched the Save by the Scan program. We're going to see a little clip of that in a minute. 134,000 people went to the website when they saw that and took a quiz. And that quiz basically said, are you eligible for screening? It asked them, are you a smoker and have you smoked at least a 30-pack year combination? Get a pack a day for 30 years or 2 packs for 15 years, whatever the combination. Are you between the ages of 55 and 80? And if you're still smoking, fine, but if you are stopped, have you stopped within the last 15 years? So right now, that's considered an individual at high risk. Former or current smoker, at least within the last 15 years, in that age group that I mentioned, and at least that 30-pack year intensity. With that level of risk, the benefit of getting screened was shown to be positive in that NSLT program. Go to the next slide. This is the video of the Saved by the Scan promotion.
After 15 years of smoking, Eva Marie quit. There's a new lung cancer screening that could save her life. You stopped smoking. Now start screening. Learn more at savedbythescan.org.
So as I said, right now there's probably about 8 million individuals in this country who fall into that category of being eligible. The last number we have through a combination of CDC reports and other, only about 5% of that population is actually getting scanned over the last several years. So patients who get scanned have that opportunity to have a better outcome if they have lung cancer. There's a couple of barriers that were put in place once Medicare decided to pay for this. The concern has been, by both commercial and Medicare, is that are people going to get inappropriately scanned? Is a patient going to come into the doctor's office and say, well, I've smoked a pack a day for the last 10 years, but I'm really worried that I have lung cancer. Can't you do a scan on me? And when you're screening the population, the best benefit in screening is when you just screen those at high risk. If you screen everybody, you're going to come up with a lot of data that really doesn't make a difference for most of the patients. It costs money, and it subjects patients to unneeded tests. So you want to get that high-risk group identified, and that's the population you want to inform about the benefits of screening, and then get them to a program that's up and running and reliably get them screened. Up, back a little bit. Okay. Can you go back, Eva? No, one more. There we go. Okay. So identifying the high-risk patients becomes key in order to get the right population screened. In order to show that you're doing a good job with your program, you need to track the data. You need to make sure that you're identifying the patient appropriately. When you get the scan done, what does the scan show? What do you do with the abnormalities that are found? What are the outcomes the following year and several years after? Because what you're doing now, you're embarking on a screening program that this patient's going to be in on a yearly basis until they reach that age where we don't feel it's beneficial anymore. So somebody comes in at age 56 with a low-dose CT scan, they're going to get at least 15 yearly scans, because once they've stopped smoking and are 15 years out, their risk drops. If they keep smoking, they're going to keep going until they reach age 75 or 77 based on the criteria. The data entry was one of the key things that Medicare put in, which a lot of people in the lung community feel has been a burden. Because part of the registry is not only data collection and reporting it to Medicare, they also put in what's called a shared decision-making criteria. We'll talk more about that later on as well. Shared decision-making is something really every patient and physician does every time they go to the office and they recommend that you get a blood test, give you an antibiotic. The doctor's basically telling you what's the benefit and the risk of what we're going to do. Same thing with a screening scan. They have to go over why you're being selected as high risk and what's the benefit to you and what's the downside. And the downside, if you read a lot of the literature over the last 4 or 5 years, is that you're going to get a scan done that may show a nodule that really is not cancer. And because of that, you're going to get a scan every year. And sometimes those nodules may even need to be biopsied, either with a needle biopsy or bronchoscopy. And therefore, you're subjecting people to tests that may be harmful, may not be needed. And therefore, there are some individuals in the country, in the medical community, who don't strongly recommend lung cancer screening in that population. We obviously think they're wrong, but we need to show more and more data about that. And the way we do that is convincing physicians and the public through Saved by the Scan programs that we did, that this is a medically proven technique. Now, the thing that's going to help that is this was back in 2011. In Europe, over the last several years, there's been a study called the Nelson study, which was done in the Netherlands, and the NSLT had 50,000 patients. The one in Netherlands had 15,000 patients. The patients were a little bit less of smokers. They had like 20-pack years, and they had scans done every year for 10 years. And their mortality benefit was shown to be a 26% improvement in men and probably even higher in women. So that data was really just released within the past 6 months. The hope is that the United States Preventive Services Task Force, which is now relooking at their recommendation, they do that every 5 years, is going to take that data into play. And they're going to come back hopefully with the recommendations not only B, but A, which makes it even more of a recommended scientific test. And we're going to hopefully get more patients meeting a criteria for at risk and getting scans done. Now we can go to the next slide. Okay. So because we thought that not enough people were getting screened, the American Thoracic Society, along with the American Lung Association, doctors from each side, I mean, most of the pulmonologists in this country are part of both organizations, but we basically said this was a joint effort to try to get together a group of people who are already doing screening at their sites and show how we're doing it. This was not meant to be a best practices or a guideline per se, because those exist already. But we know that when hospitals put up a study or a screening program, they don't always have the same resources. The people at the Leahy Clinic who've been doing it for a number of years have much different resources and experience compared to Geisinger, which is still a very good hospital, but they haven't been doing it as long. Cleveland Clinic, Mayo Clinic, they all have programs, but they all do it differently. And these screening programs can't just be at those centers because we're going to miss all the population needs that being done. So Williamsport Hospital, where I grew up, they should try to have a screening program there as well. There are some places that are more rural where they're developing mobile CT scans that go out in a Winnebago and do screening in the high-risk population. So we need to figure out a way that physicians, administrators, radiologists, all key people in this, know the benefit of screening, get the right population screened, and therefore improve mortality. So this was not a guideline, but it was meant to be this is what we do at Cleveland Clinic, this is what we do at Christiana, which I'm at Wilmington in Delaware, Christiana Health System, and an interactive guide. And you all have the PDF, but the more important thing was that we wanted to make this into a website that was searchable, interactive, and could be updated with new information. Next slide. Okay. So in order to get this rolling, we feel that you need to have champions in the setting, in the community setting. Certainly physician champions, whether it's the pulmonologist, thoracic surgeon, radiologist, and you need to have the people who have the purse strings, the administrators at the hospitals who are going to say, yes, we'll put up a program that might need a nurse navigator, it might need more time for the radiologist to read these scans, it might need more marketing to tell patients about it, but you need to have that support from your administrators as well as from your physician community. Once you have those people together, just like it's important to track the data, you have to make sure that you're doing this in the right way. You have to set up a system where abnormal studies are looked at appropriately by the right physicians, and often that's called an MDC, or a multidisciplinary clinic, that usually is made up of a pulmonologist, radiologist, sometimes an oncologist, thoracic surgeon, and they look at the abnormal studies, and we'll talk about how they're graded, and they decide, is this patient safe just to get another scan next year, or is there something that needs to be done in the meantime? Or do they need a biopsy? Okay. You have to follow the metrics of quality. In everything we do in medicine right now, people need to show outcomes that are valuable, and most of those outcomes are based on metrics of mortality, morbidity, cost, length of stay, complications from procedures. All those things have to be tracked. Because one of the other worries with the original NSLT was, well, their complication rate was 5%, but that was done in a well-controlled clinical trial. What's going to happen out in the boondocks of North Dakota? What's going to happen across the country if patients go and get biopsies? There's going to be a higher complication rate. And there have been studies that suggest that could be the case, but most of those studies are looking at populations that are different from the at-risk population. This at-risk population is generally a smoker who's otherwise pretty healthy. If you have COPD and you're on oxygen, you don't get screened for lung cancer because, unfortunately, to put it in a very crass way, you're probably going to die from something else, not from an early detected lung cancer. So these are patients who are going to benefit because they're otherwise going to live long enough that that cancer is not going to kill them. All right. You're going to hear a lot more about insurance later on when Deb talks. And you need to make sure that you're always keeping track of what you're doing, marketing it more, and getting more and more patients into the program. As I said, right now it's a very low number that are getting screened. Any questions so far? Are we going too fast? Are we going too slow, Eva? Okay. All right. This is, we're going to get actually to the website in a minute, but this is what the website covers. So we broke it down into sections. There were about 20 physicians on this panel, and coming from, when we list in the website all the different hospitals that were involved. And as I said, this was not a guideline. This is what we do and how we've been doing it at each of those hospitals. So we set it up such that if you're an institution trying to set up a program, you're going to say, well, who do I need to get as far as administrative support? So we had that question. And then we had people at the different hospitals put the answers in on the website. Who should make up my multidisciplinary clinic team? Everybody put in how they did it. Should I have a nurse navigator? Should I have a centralized program versus decentralized? We're going to talk about that. So you have to figure out all those different things. And as I said, you need to have champions. You need to have the involvement of administrators and physicians, identify the right populations, and get them through that appropriate counseling step, that shared decision-making, because that's important for the Medicare population. In order to get reimbursed, they have to have that shared decision-making. At this point, I'm going to interject a little bit that when all the different organizations were lobbying about getting coverage for this, the only organization that stood out as saying, no, we don't think we want to do this, was the Academy of Family Practice. Unfortunately, they see a lot of the people who are at risk because these are otherwise healthy people who are still smoking. And the Academy of Family Practice just felt there wasn't enough evidence to warrant putting a lot of people through this scan because they thought there would be a lot of false positives. And that's been a tricky term over the years. False positive is different from a false discovery rate. And I only recently heard a way to try to put this that makes a little more sense to me. We all have some moles on our skin. So let's say that the government said, you know, we'll really save lives if everybody went to a dermatologist and had pictures taken of all their moles as a baseline. Now, some of you are going to go and have moles that just look like moles and nothing has to be done. But some of those moles are going to look suspicious. And the dermatologist may say, well, we got to watch that a little closer, or we may need to biopsy it. Well, that's the same thing that happens with your lungs. If you line up 100 people for a CAT scan of the chest, probably 80 to 90 of them will have a little spot, a little scar, something that is abnormal on that scan. It doesn't mean it's cancer, but that's something, if it's big enough, and 6 millimeters is the cutoff, if it's big enough, it needs to be watched. And the number of those that change is low, probably more in the 20% range. But again, you have a high number that are found in that first scan, 80 to 90%. And people say, well, that's too high of a false positive rate. Not false positive, it's false discovery. It only becomes positive if that thing changes over the course of the next 3 to 6 months, and then you have to have an intervention done. But if it's stable, you just got that yearly scan, and you know that's your baseline, just like your baseline mole didn't need anything done, but that little nodule had probably been with you all your life from an old scar as a child. We're hoping that the American Academy of Family Medicine, Family Practice will change their thinking with the new data that I just mentioned from the Netherlands, but we'll have to wait and see. Let's go to the next slide and see where we're. So I guess, are we at the interaction, the website now? How are we doing on time here? Okay. All right, we're going to switch to live action. And I don't know, I mean, you can see a little bit from the handout you have, the PDF. I don't know if you can read across the top. But why don't you go through, on the next slide, you have mentioned where you want to hit one of the interactive sites. So this is how it's set up. We have the radiology requirements, initiating a program. These are different categories. A whole section on shared decision-making, a section on how to deal with your referring physicians. We also have a list of resources that do include the actual guidelines that were put out by the different societies, medical societies. We also talk about how to navigate and data track. Next slide. So if you go to this first page where it's initiating lung cancer screening program, you can click on any one of these boxes to start to get information that you might be searching for. You don't have to go through this, obviously, page by page. We wanted this to be, you go to it, put your question in, search for something up in the bar, get your answer, and then move on. You don't have to sit and read that whole PDF, obviously. Some of you may have programs that are up and running, but you need to tweak it a little bit. You want to say, well, gee, maybe we want to do this a little differently. How do they do this at Christiana or the Cleveland Clinic or the Leahy Clinic? And you can look it up in there. Okay. Which one? You want to go to the radiology requirements? Okay. So let's go to, let me go to the metrics, the first one, establishing radiology and program quality metrics. On the website. Yeah. Sorry, I'm making this confusing for you. Yep, the very first one. Okay, so if you scroll down a little bit. Okay. So there's the question. We thought this would be a question that a lot of administrators may ask. How do you gain support from administrators? Oh, it's like, all right, you can click on that, on drop down on the arrow and see what you get, Eva. Okay. The initials at the top are the initials of the member of the team and what institution they're from. So not everybody had the same answer about how they went to their administrators and set up a program. So you could read through how they did it. AR actually stands for me, so I did that one. Is there any more on that one? So we have several different institutions who answered that question. If you go to the next one and click on the arrow over there, provide a description of your program, including structure and governance. So again, you can see how they did this. I think that first one is the Leahy Clinic. Okay. All right. The other one I want to go to is the what happens when the scan is abnormal. Can you go put in RADS, R-A-D-S? Many of you may know that mammograms, screening mammograms, I think it's called BRADS. It's a very standardized reporting tool that radiologists do when they read mammograms, and that's been in place for a number of years. And the idea that the American College of Radiology was hoping to do, and they have, is standardize a reporting tool for people who go for a low-dose CT scan. All right. See if we can actually pull up the RADS during the CT reporting. See what that shows you. That's it. Okay. There, hit that, how the results of the LS are reported by the radio, that one. Okay. Use lung RADS. Okay. Lung RADS basically has a category from 0 up to 4. 0, 1, 2, and 3 are felt to be benign findings. Nothing or small nodules are included in that. Once you get to a category 4, what you're saying is this is something that's at least 6 millimeters in size and at least needs watching. And that watching might mean another scan in 3 months or 6 months, depending on the risk factors for the patient. And if that 1 in 3 to 6 months doesn't show any change, you probably say, all right, we can wait a year and see what it looks like. If it's a category 4, but has some other suspicions to it, certainly if it's bigger, it's 8 to 10 millimeters, that's something that the multidisciplinary clinic would probably have a discussion about. This is big enough to think about biopsying. It's big enough to think about doing some other scans that may be helpful. Remember, this is a low-dose CT scan. It mainly shows things by looking at different densities. If a scan is in that 8 to 10 millimeter or higher mark, the multidisciplinary clinic may say, why don't we do a PET scan? Now, a PET scan costs a lot more money, but it's a different type of scan because it shows activity in that area. If this 10 millimeter nodule lights up on a PET scan, it suggests that it's either an infection or an active tumor. If it doesn't light up, really low likelihood that it's a cancer, but it still warrants follow-up because it's big enough. The PET scan could be an intervening study that needs to be done. Now, that's low risk, but yet some people would say, well, that's an unnecessary test. Well, it's only unnecessary if ultimately the patient turns out never to have a cancer. But that's what you want to do in the first place. You don't want them to have a cancer. It's a high-risk person who doesn't want to die from lung cancer. That's why you don't screen everybody. You don't screen people at low risk. You don't want them getting PET scans done. If that 10 millimeter nodule did show a little bit of lighting up in the PET scan, the radiologist and the pulmonologist might say a needle biopsy is necessary. Or they might say a bronchoscopy is necessary. Now, done in the right hands, those techniques, either interventional pulmonologists or thoracic surgeons, have a very low complication rate. They're outpatient procedures, Sometimes a little bit of air leaks in. They have to have a little chest tube put in, but it's a very low-risk procedure. And any community should have a good idea as to how well their interventional radiologists and pulmonologists and thoracic surgeons are about doing surgery. I'm sure Dr. Moritz, when he's here, will talk about complications rates in their health system. And when you do that shared decision-making as a physician, I should feel confident saying, look, I think you need to have this biopsy done. I have a lot of confidence in the thoracic surgeon who's going to do it. Low risk, but the benefit is we may find a cancer early and potentially cure it. That's the message you have to keep giving to the patient. Not just doing this to get the test done. If it's a positive test, if it turns out to be a stage 1 cancer, you've saved them from dying from lung cancer. Right now, if you get diagnosed with lung cancer, 50% of the people who get diagnosed today will not be alive a year from today because it's often found in an advanced stage. You don't want that to happen. You want that to be at stage 1 or 2. Let's go to, no, we're kind of out of order here. Go to another category and we'll see what we find here. Right now, think about if you're either, how many people actually have a screening program up and running right now? So a few, okay. Some are seriously thinking about it, hopefully, okay. Is there any particular question you have right now that you might go to this and search for? What kind of program do you have? You use a Nurse Navigator by any chance? You put Nurse Navigator in the search bar and we'll see what we have. In Delaware, we have a program through the state. It's called Screening for Life. Prostate, colorectal, and we added lung cancer screening when this came out. And Delaware is a small state, more manageable than Pennsylvania maybe, I don't know. But we only have really 3 big hospital systems in the state. And they work together to help make sure that certainly those without any insurance who fit this criteria can get scanned in the different locales. And we try to work together to make sure we're tracking the right things, getting the right quality metrics. And we do have a Nurse Navigator that sits, I think, in Dover mainly, and handles those individuals across the state. And the Nurse Navigator becomes important when you're trying to decide how are you going to make sure patients go to the next step. Once they get screened and that report gets sent out to their referring doctor, what's the next step? And there's a difference between a centralized program and a decentralized. The centralized one is where me as a physician think this patient fits the criteria, they need to have a scan done. And I'll send them to the centralized place. A Nurse Navigator, a nurse will talk to them, make sure the criteria for eligibility is met, and do that shared decision making. Online and in this website, there are shared decision-making tools, like a little checkbox, make sure the risk of the smoking risk is there, family history is there, other things that kind of help calculate what the patient's risks are. And then you also talk to the patient about the downsides. After that shared decision-making visit, they usually go get the scan right then and there. The report comes back usually within 24 hours. And that central Nurse Navigator will call the referring physician and the patient and say, nothing seen, we'll see you in a year, great. They may say there's a nodule there that needs further follow-up, need to have that set up in 3 to 6 months, and the Nurse Navigator will do it. So in the central program, the Nurse Navigator makes sure nobody falls through the cracks. She'll also be the one who will make sure a year from now that people who should come back for a yearly scan is notified. Letters are sent out. And there is a drop-off rate. People tend not to come back on a yearly basis. But you need somebody to kind of track that. In a decentralized program, you may have a physician send the patient in, they get the scan, they get the report back, and then they have to decide what to do next. They may say, well, I'm going to send you to my referral to my pulmonologist that I know. Or I'm going to send you to the thoracic surgeon. Or they may say, I think you need a PET scan. So that's really where the physician outside the centralized program becomes the main person to make sure things get done in the right manner. Shared decision-making encounter, make sure that you have the order there. It's very easy for the patient. This is not a CT scan that needs intravenous contrast. You don't have to get into a gown, and it's a very quick scan. These scanners have become very quick over the last 20, 30 years. Radiologist reads it in that RADS category and then sends the report out. What I didn't mention in that RADS category, and what's becoming more and more important as we hopefully get more people screened, is something called incidental findings. Incidental findings doesn't mean they're not important. It means they're not part of the lung cancer reporting tool. They may find calcification in a coronary artery. They may find a dilated or large hiatal hernia. So something outside of the area of lung cancer is found by the radiologist, as reported. And what we're finding out now is if you use all the data that you get in this low-dose CT scan, you may actually be starting to pick up disease that is also tobacco-related. The patients are also at risk for heart disease. And if you find coronary calcification on this low-dose CT scan, and they have not been seen by a cardiologist, and they don't have any cholesterol-lowering drugs, that PCP will benefit from that information as well. So you want the incidental findings to be reported and acted upon in that manner as well. Finding thoracic aneurysms and saving a patient from an acute dissection and death has been found on these scans as well. Because unfortunately, tobacco puts a lot of risk in patients. Cardiovascular risk, lung cancer risk, lung disease risk. Finding early emphysema is also looked at as far as these scans are showing emphysema in patients who still have normal spirometry. But that may be a population where if we intervene sooner, we may benefit them. And how do we intervene the best for this population? We get them off cigarettes. And lung cancer screening is a very important teachable moment for patients who are still smoking. Part of Medicare's criteria is that you need to have a smoking cessation opportunity at any of your sites that are going to get reimbursed by Medicare. And there's a group of, I think it's SCALE, smoking cessation and enhancement based on lung cancer screening programs. Maybe Jennifer knows more about that. But it's a group of about 6 to 10 sites across the country that are looking at different ways that smoking cessation can be implemented at this screening center. It's a little different from in a doctor's office. Again, these are people healthy who think they're doing pretty well even though they're smoking. And the approach to them to get them off cigarettes may be a little different from the person who has 2 packs a day, is on 3 inhalers, and needs oxygen. So what's the right way to implement smoking cessation in this setting is being looked at across the country and trying to find the right way to do it. Many people were worried that a scan got done and looked normal. If you were still smoking, you say, great, I still have a great normal scan, I can keep smoking. Obviously the wrong message. But those are the kind of things that we have to be prepared for when we do a smoking cessation program. Okay. Where do we move to here? The screening? Let's go forward a little bit. Okay. All right, this just reiterates the criteria. The age is a little different from commercial to Medicare. The original NSLT had age 55 to 74. The United States Preventive Services Task Force said 55 to 80. Medicare says 55 to 77. Question comes up, well, when the patient is 77, they get their last scan, what do you do the next year? And that's a real shared decision-making minute with the patient, because they're going to say, you've been watching it all this time, why don't I get another scan? And you're going to say, well, you don't deserve it because we think you're going to die from something else before the lung cancer gets you. Bad message. So you have to, at that point, decide, do you still get the scan for other reasons? Maybe the insurance won't cover it, but that's a decision you have to have with the patient. The smoking pack years I talked about, still smoking within 15 years, and healthy enough to tolerate treatment for early diagnosed lung cancer. If you have a patient with severe heart disease, severe renal failure, even if they have no lung problem, they are too high risk to undergo a thoracotomy and get a lung cancer resected. So again, not the right person to screen because you may find a cancer you can't do much about. Now, having said that, there are people that will say, radiation therapy now can sometimes cure people. So even though they can't have surgery, should you still screen them and treat them with radiation if you find a cancer? That's outside the screening protocol. You really shouldn't do that across the board, but that's where the physician and the patient make the decision about what's best for them. And throughout all this, that's the message that really needs to be there. We can put out guidelines and we can put out recommendations and all those things, but the physician and the patient have to have trust in each other's rapport and collaboration to say what's best for me at this point in time. Okay, let's go to the next. Okay, a lot on there. Shared decision making. These are all on the website. There's different forms to create shared decision making results. What time am I supposed to go to? 11:30. I think I hit a lot of the high points, but I want to make sure, what other questions might you have? Yes?
What have you found to be the best way to track and do data reporting?
Good question. The way we do it at Christiana, what's the best way to track the data from the screening? At Christiana Care, we use an Excel spreadsheet. The nurse navigator kind of puts the patient's name, the date, their eligibility, when they got the scan done, what the RADS score was, what was the next step. So it's time intensive. There are software programs that are available. LungView, I know that there's probably at least 4 or 5 proprietary programs out there. I know that we looked at one that the Cleveland Clinic uses. Many of these programs incorporate a pulmonary nodule software as well, because what you want to do, let's go back to your original question. The software can track these, and therefore you have a lot less manpower needed. These usually cost in the range of a couple $100,000 to implement the software and make it work with whatever your electronic system is in your healthcare system. Because at Christiana, we use Cerner, and unfortunately, when we asked them to buy the software, the Cerner people said, oh, we can do that. It'll just take us another 3 or 4 years to do it, but we can do that. Right? So it's a trade-off of money up front to help get the program on a smooth, reliable tracking system. The pulmonary nodules in general, that patients come into the ER with chest pain and they get a CAT scan, they find a 6-millimeter nodule, an incidental finding. It's not in a high-risk population. What do you do with those? Many of those have to be followed as well, but that's outside the lung cancer screening program. And that's where the software like this can keep people on track. An example, Christiana Care, we have 5,000 nodules found every year, incidentally, from scans that are done for gallbladder disease, chest pain, other things. And sometimes those things fall through the cracks. And 6 months later, somebody comes in with a nodule that's now bigger and should have been biopsied 6 months ago. So software can help, but it's costly. Okay. Does that answer your question a little bit? I mean, it depends on your resources. That's why we thought having a program like this, some patients will use manpower, Excel spreadsheets. Other places will have a software program that tracks it. Yes, but that can be done by hand as well, and we do that by hand. It goes to the American College of Radiology has the registry. That's the only registry right now that Medicare approves, so everybody who gets reimbursed by Medicare has to have that data sent in. And the American College of Radiology accreditates most of these centers based on the radiologist's experience, the quality of the CT scanner that's at each site, and they provide CMEs to the radiologists who are performing the scans. And that's another variation from place to place. You may have some places where there's 2 radiologists who read all the CAT scans of the chest. They become very proficient at it. They know the lung RAD score very well, and they're very reliable. Smaller institution might have a practice of 18 radiologists who have to do everything, and they may do a week of doing CT scans of the chest, and the next week they read x-rays of the knee. So proficiency and specialization occurs in that situation as well. That's why the lung RADS data was used to kind of make it all similar. Even if you're not somebody who spends every day reading a CAT scan of the chest, you have some criteria you can follow to report that lung RADS. Okay. Yes? That number comes out of the fact that if you are a smoker and you stop, and you kind of look at your age and your mortality and lung function over the course of the next 15 to 30 years, your likelihood of dying from a tobacco-related problem starts to get back to the non-smoker's rate at about 15 years. Never quite gets back there, but that's the reason. They figure at 15 years, you're probably lucky now. You quit smoking, you beat the tobacco issue. I'm sorry, did you want to repeat the question? The significance of 15 years. Everybody got that? Okay. Other questions? Give it a try if we're going to, yeah. Let's see, pick out something that, a burning question for you, Ebba. And I said through here we have all the current recommendations and guidelines from the American Thoracic Society, the Cancer Society, the Lung Association. Those are all part of this website. And again, the website itself is really just a tool to say, this is what we do at our institution. And we're working on a way to try to update this and make it more interactive. That'll probably take another 6 months or so to make that a occur. Again, that takes a little bit of time and money from our staff. But the important thing, it was really a good opportunity for both the Thoracic Society and the Lung Association to work together in this endeavor, because we really think, as pulmonologists, we really feel this has been a game changer as far as trying to diagnose lung cancer early. I mentioned the statistics earlier on that if you're stage 1, at least a 54% likelihood of survival 5 years. Stage 4, 5%. Big difference. Program navigation and data tracking. So, what do you want to see under there? Well, you're not alone. That's why we're doing this. We all think there's better ways to do it, but it's all based on our resources. Data tracking Q&A. The first one talks about how do you track the incidental findings for the non-screening CT scans. That's where if they come in with a gallbladder attack. How do you report coronary calcifications? Coronary calcifications, sometimes what the lung RADS does, it's either mild, moderate, or severe. There are more specific calcification scores. That, again, depends on whether or not your radiologist is using software that will do that. And some radiologists actually will do a specific cardiac CT scan if they get a hint on here that something is abnormal. Because calcification of the coronary arteries is a pretty good marker of disease and really requires intervention, especially if it's somebody who has no known heart disease at the time.
And 12 months between, like, so you have a screening and something looks suspicious?
Yeah,
You have a screening and something looks suspicious?
When you have that follow-up, if it's not quite 12 months, if it's prior to that, it's no longer a screening then. For insurance purposes, it has to be
Right.
a diagnostic
right,
at that point?
Exactly. So if something shows up on that initial scan that really warrants evaluation, and the recommendations usually say if it's highly suspicious, they recommend at least a 3-month follow-up. If at that time no changes have occurred, you might say we'll get another one in 6 months or 9 months, but that is more of a diagnostic study at that point. But if there's nothing done or needed to be done, that next yearly scan is covered by insurance according to the law. That's not always the case. Maybe Deb will get into this, but Medicaid is kind of iffy across the country as to whether or not they cover low-dose screening on populations, because that's a state-based program different from Medicare. Okay. And not all of them have to follow the Affordable Care Act, because some of them are expansion programs, and I mean, it gets complicated. Anything else in there? Anything about smoking cessation? Let's hit the smoking cessation. Got a resident specialist in the crowd here. The Leahy Clinic, I know a number of places have. The Leahy Clinic published their data with regard to intervening on smoking cessation. They found that in their program, the success rate of keeping people off cigarettes in the lung cancer screening population was better than just the general use of smoking cessation in the community. And you probably have to say, well, this is maybe a more motivated group because they're already taking the step of getting screened. They're worried, they're concerned about their health, so you would think they may be a population who would take on smoking cessation more seriously. The resources available vary from place to place. We have a quit line. A lot of places have quit lines. We do offer face-to-face counseling. We have a smoking cessation counselor at the shared decision-making site as well, so they can see that person at the same time as they do the shared decision-making and get their scan done.
About the smoking cessation counselor. There's a question in our organization about the billing piece of that. Is that just something that's billed in with the visit, or can
I
that
know there are,
practitioner bill separately?
Somebody else could jump in, but I think I'll answer first. I think in our program we actually don't charge for that. I think there are billing codes for that. We have a Delaware quit line that's supplied by the state, but I'm going to let Jennifer from the American Lung Association answer that.
Hi, everyone. Jennifer Folkenroth, National Senior Director for Tobacco Programs with American Lung Association. We do have a tobacco cessation resource guide for you on lung.org that you can access that has the list of all of the codings to bill for cessation services being provided. as well as providing guidance on the various different plans and what is covered. Thank you.
Thanks, Jennifer. Anything else about the website? You think?
All right, everyone. I think we're going to resume the program. If you'd like to have your seat. Thank you. Dr. Rizzo is back because he has so much more to say. He's got a lot more to say.
Well, we were worried that the implementation guide wouldn't fill the whole hour, and I don't think it did. But because more importantly, it's on a website. We want you to go explore it. Put things in, search things. But what I wanted to, we decided to touch upon a few more things that maybe I glossed over a little bit. I keep talking about eligibility and criteria for screening. Now, the reason we use tobacco is the #1 cause of lung cancer. Cause a lot of other things, but is the biggest risk factor. We know it's not the only risk factor. And if you look at other organizations, NCCN, the National Comprehensive Cancer Network, they have some other criteria that they use when they put down reasons to screen individuals. Some of that includes family history, because we know that genetics can play a role with regard to cancer. They also include some things that are considered occupational exposures. Asbestos, for example, is considered a risk factor for lung cancer. Now, those other risk factors right now are not technically covered by commercial insurance with regard to the Affordable Care Act because they don't meet those initial criteria. But that's where the shared decision-making comes in, even in a patient who maybe isn't smoking is enough to meet that criteria, but if they have a background of asbestos exposure, they have a family history of lung cancer, those are reasons to think about doing maybe a diagnostic scan at that point, especially if they have symptoms. So we know that cigarette smoke, secondhand smoke is a big risk factor for lung cancer as well. And then really the second most common reason in this country is radon. And radon is something that, as Lung Association, I know we work with the radon people, and I think there's some in the room, right? Yeah. So, I mean, we'd like to give you a little stage if you want. We want to raise awareness about radon. And certainly you being here can be helpful to the rest of us to say like what you're doing, what you think we should be doing. Not to put you on the spot, but I did.
Hello. Oh.
There you go.
Good morning, everybody. My name is Bob Lewis. I'm the program manager for the Radon Division with the Department of Environmental Protection down in Harrisburg. So thank you, Dr. Rizzo, for the short opportunity. I'll make just a few comments here. I've been saying this for quite a few years, and it's a dubious distinction that Pennsylvania may be one of the worst, if not the worst, states in the country for radon problems. If you look at our average, the average in Pennsylvania basements is about 7 units or picocuries per liter, sort of like pounds and ounces, just the units that are associated with this number. 7, the EPA's guideline across the country is 4, so we're almost twice the EPA's guideline in the basement. Our average upstairs is about 3.5, so there we're just about what the EPA's guideline is. We have a very wide geographic distribution of radon problems, south, north, south, east, west, basically. We have also a lot of what I would consider high-end data. We have many, many homes that are over 15, 20, 30, 40. Joe was just telling me about one of her colleagues had 40 picocuries per liter, so 10 times EPA's guideline. So those are getting to be significant concentrations of radon. Radon is a radioactive gas. It's in our home. It builds up in our homes. We happen to be in our homes, and what are we doing in our homes? We're breathing. So it's going right down. Upper tracheobronchial region is where the cancers occur from radon, basically. The Environmental Protection Agency has estimated that out of the, 154,000 lung cancer deaths a year, roughly 21,000 of those are due to radon. And most of those 21,000, I think it's about 18,900 are in smokers, and the remaining 2,000, 3,000 are in non-smokers. So it's the primary cause of lung cancer in the non-smoking population. So we certainly take it very seriously. We've been dealing with radon problems in the country for about 35 years now. And I mean, just based on our size of our staff, is one reason why Pennsylvania is so seriously involved in this. And we do a lot of public awareness. Just January was our Radon Action Month for Pennsylvania, as well as through the entire country. We ran a PSA. Maybe some of you saw our public service announcement, a little 30-second blurb. Basically, Denise and Jamie and Maria do a lot of public outreach at health fairs, realtors, schools, et cetera, et cetera. I could take any questions or just leave it at that. Yes, go ahead. One of the perfect opportunity. One of the things we do is we work with the American Lung Association. Many of you know Kevin Stewart. He's been a great work with us. I don't know how many years, 10, 15, 20 years or something. And right now, we have a grant with them to do. We've done it different ways in the past. Sometimes he has a general website that he opens up for the Commonwealth in general. People find out about it through different means and just come online. We've thought it's a little bit better because of some of our high areas to target these surveys, which we've done now for the last 2 or 3 years. We get all the data submitted to us from the industry. So we have about 2 million test results right now. So it's easy for us to go and find and say, okay, Lower Paxton Township or something in Monroe County or something has a significantly higher average than the 7, for instance. So then we, Denise primarily, touches base with the township, send us a mailing list if you want. If they do, then we forward that to Kevin, and then he then sends the test kits to people that submit to that for requesting a free test kit. So we think that's a little bit better way to get the higher risk people, just like we're doing here.
Thank you.
Oh, thank you.
Glad you were here today.
Oh, glad to be here.
So again, tobacco is the biggest risk factor, but there are others. And air pollution in general. Several years ago, the World Health Organization said air pollution, particulate matter, ozone, is a risk factor for lung cancer as well. Part of the concern when you get past the screening in the high-risk population is, well, we know people who don't smoke get cancer as well. And why don't we screen for that? Well, right now, there's no good screen that is available for people who don't have any obvious risks. I know we all probably hear stories about otherwise healthy 30, 40-year-old woman who all of a sudden has stage 4 lung cancer because a little shoulder pain, they do an x-ray and they find this big mass. There's a lot of work being done to try and figure out how we can do maybe something less invasive than even a CAT scan, blood tests, serum markers. And can we look at genetics? Can we look at a family history and maybe figure out, is there a gene in this family that does put them at risk and maybe they warrant getting intervention well before there's any other signs of any disease. So we need to do that. The non-smoking population doesn't want to feel left out about being cured from lung cancer. Nobody deserves to get it. It's one of our taglines, nobody deserves to get lung cancer. And we also want to make sure that people who are smokers unfortunately have to deal with the fact that there's a stigma associated with smoking, not only in lung cancer, but COPD, emphysema. Even among physicians, there's still a stigma that, they don't say it, but this patient is suffering from COPD because they smoked 2 packs a day for 40 years. Doesn't mean you shouldn't be treated, but there's still the little bit of a feeling that they brought it on themselves. We don't do that with people who are obese. We don't do that with people who eat a lot of butter and cholesterol in their diet and have heart disease. So why do we do it with smokers? No good answer there. But we want to make sure that that stigma is not keeping people from being sent for screening. Because if you're otherwise healthy person, 2-pack-a-day smoker for the last 20 years, you meet the criteria and you should be screened. And we don't want that stigma or the feeling of that physician not to send patients in to get screened. So it's a constant issue that we strive to deal with at the Lung Association. The other term, I know recently one of our board members is one of a stickler. She's a non-smoker who had advanced lung cancer. And she doesn't like us to talk about prevention as much as she likes to talk about risk reduction. Because prevention means, okay, you don't smoke. You're just addressing the person who got cancer from the smoking. But there are other risk factors, and we need to address risk reduction in general, whether it's radon, secondhand smoke, occupational exposures, air pollution, all of which things that the Lung Association is trying to work on. So we want to address them as well. We are working a lot with our research arm of the Lung Association. We're supporting, along with Stand Up to Cancer and Longevity, one of the dream teams in lung cancer. It's called one of the interception teams. This group of researchers are looking at swabs from the nasal membranes. They're looking at the DNA that comes out of those cells, and they're looking at whether or not they can code the genes in there that might be indicators of cancer. Somebody's high risk of developing cancer. We know there are genes and DNA segments that are what they call oncogenes. They promote the development of cancer, more mutations in those patients who have those oncogenes. So we're helping support early diagnosis that way. We also work with people who are very interested in what's called biomarkers that may be blood tests. And more recently, we also are talking to a company who's measuring breath condensates. You breathe into a device, and some of the volatile carbon compounds in there have a signature that are a little higher in patients who either have or are at risk for lung cancer. So we're trying to do things beyond just screening the very high risk, which is important to do, but we know there are a lot of individuals that get lung cancer who aren't in that high-risk population. We want to try to come up with a way to answer that group of individuals so they don't present with that stage 4 and have a very low survival rate. I wanted also to then throw things back to Jennifer a little bit. She introduced herself earlier, but smoking cessation, not only in the setting of lung cancer screening, is something that's important as a lung association for us to do. And I want to give Jennifer a few minutes to talk about that.
Thank you so much, Dr. Rizzo. Hi, everyone. How many of you currently work with tobacco cessation or are trained tobacco cessation counselors? Okay. As I said before, American Lung Association has a variety of different resources, and one thing I will be asking Eva to do is to bring up our resource library on lung.org that's not only a billing cessation guide, but also one-pagers and really helpful resources for your patients, navigating the system of how do they know what's covered by their insurance. We work with a lot of individuals that are looking for cessation services and don't realize that they can get that nicotine patch or gum at no cost through their insurance if a prescription is provided by their primary care provider. So a lot of really helpful documents on that. Let me see. I actually emailed you, Eva, the link. While Eva's pulling that up, I will just give you a brief overview of American Lung Association's 4 different tobacco cessation modalities. Our evidence-based proven effective cessation program is freedom from smoking. How many of you know freedom from smoking? Oh, my heart. Been around for over 40 years, have assisted over 1 million tobacco users in ending their addiction to nicotine. It is available in 4 different modalities. We have an in-person group cessation clinic. We have Freedom from Smoking Plus, which is online 12-month membership. We also have the lung helpline working through our respiratory therapists, registered nurses, and certified tobacco treatment specialists to do it telephonically through the 8 sessions. And then, of course, we have the self-help booklet for those individuals seeking a self-help guide. Thank you so much, Eva. So what you're seeing here is our resource library. So not only knowing about the billing, the coding, understanding nicotine dependence and treatment, how to address it among specific target populations such as pregnancy. We have a variety of different just basic resources, behavioral and mental health, which of course is a target population that is disproportionately impacted by tobacco use. So please come visit us and get some of these resources, not only for yourselves, but also for your patients. In addition to the 4 modalities for freedom from smoking that are available, we also offer tobacco treatment planning sessions. And one thing we have noticed is an increase in the popularity of tobacco treatment planning sessions. Of course, this follows the Triangle of Addiction, which is a module really learned through the training of tobacco treatment specialists and helps you to build a comprehensive plan that addresses the psychological, the physical, and the behavioral components of the addiction. Normally, when I sit down with an individual to help them build a treatment plan, I go through all 3 angles of that addiction. And my first question to them is, what are you doing to address the physical? What are you doing to address the psychological? What are you doing to address the behavioral? And that's when I can find that missing link, strengthen and make sure their treatment plan is truly comprehensive, and get them on the road to freedom. Through tobacco treatment planning, freedom from smoking counseling, also brief intervention, in terms of billing cessation. So there are 3 different levels when it comes to billing insurance. You have a brief intervention, which is less than 3 minutes. You have intermediate, which is 3 to 10 minutes, or intensive counseling, which is 10 minutes or more. American Lung Association's Freedom from Smoking program tobacco treatment planning session is 45 to 60 minutes with our counselors, so of course that goes beyond the minimum 10 minutes. However, that is completely billable. The billing cessation guide, second tab. You're good. Thank you, sweetie. Second tab at the top. And I was sending this to my new friend Helen, who asked the question earlier, who works over at Penn State Hershey, and we're going to help her get some tobacco cessation programming up and running in her neck of the woods. But this billing cessation guide, it gives a complete overview of the different structures of what is required by each of the plans, also continuing down through all of the codes that you're going to need to bill for brief intervention, intermediate, as well as intensive counseling. Some different strategies. We even have a section on here in case for some reason your claim is denied, how to kind of navigate around that denial and resubmit the claim. What's covered, easy, to the point, diagnosis codes even. So please feel free to use this to your advantage. If you do have any questions about any of these resources, I'm available at any time, jennifer.folkenroth@lung.org. In addition, I do want to let you know how we have really integrated lung cancer screening in with freedom from smoking, because we know hand in hand it's so very important not only for individuals with lung cancer to ask them if they're tobacco users and to help connect them with evidence-based, proven effective cessation strategies. In the same return, when we are serving individuals that are voluntarily coming in to quit in our programs, we want to make sure that they are being screened for high risk for lung cancer. So American Lung Association has integrated this into our intake for freedom from smoking programs to ensure that we are testing and asking these important questions and being able to capture folks on the tobacco side as well. So very important working together. Let me see. Modalities. Freedom from smoking. Jennifer Folkenroth. Any questions from the room? Dr. Rizzo.
In order to get the billing, do you need to be a licensed practitioner?
Excellent question.
Incident 2 or something like that?
Yeah, it's a great question. So those that are billable cessation providers are different per plan. So you will need to look in to see what the list of billable cessation providers is per which plan you're looking to submit to. We are trying to expand that. Of course, your physicians are billable. Many times your RNs, RTs, a lot of your clinical practice, you will be billable. Certified tobacco treatment specialists, some lists have us on, and others do not. However, there is a national certificate now to certify us across the entire board and bring us all together to make us billable providers. So stay tuned for that. Thanks for the question. Chelsea.
Would you be able to tell us about some of the programs that are available here in Pennsylvania that the American Lung Association offers through the Pennsylvania Department of Health?
Another great question. So through the Pennsylvania Department of Health, of course, they are so very gracious with their dollars to help support cessation programming for all here across all 67 states in Pennsylvania. Each of the regions have a regional primary contractor that sets up free access to these cessation services, in-person group cessation clinic, also the 1-800-QUIT-NOW, so calling our telephonic counselors to really help navigate you through the system. We also have the self-help guides and the Freedom from Smoking Plus, and of course 1-800-QUIT-NOW also has an online resource as well. So tons of access and availability. It's so very important to lower the barriers in helping to connect individuals with free cessation services that will ultimately change their lives. So please visit the Pennsylvania Department of Health website for a list of those regional primary contractors to reach out to see which programs may be available at no charge in your area. Or, of course, call 1-800-QUIT-NOW. Thanks for the question, Chelsea. Any other questions? Okay. Thank you.
Thank you, Jennifer, and Dr. Rizzo, thank you as well. Our next speaker is Deb Brown. She is the Chief Mission Officer for the American Lung Association, and Deb is going to speak about insurance reimbursement.
Thank you. And I'm going to stand up here if that's okay. Eva does everything. So I think we've all heard, but I think it's worth repeating, that lung cancer is the nation's leading cancer killer of both men and women, accounting for approximately 24% of cancer deaths in the United States. Only 16% of lung cancer cases are diagnosed early when the disease is most treatable. And low-dose CT screening among those at high risk for lung cancer reduces the lung cancer death rate by up to 20%. In December of 2013, the U.S. Preventive Services Task Force, and we're going to call it USP STF. I'm going to try and make sure I keep getting those letters all right. But they gave lung cancer screening for individuals at high risk for lung cancer a B grade, and you've heard Dr. Rizzo mention this. The Affordable Care Act required most private insurance plans to cover any preventive services with an A or a B grade at no cost to the patients. The USP STF guidelines for high-risk populations are the 55 to 80-year-old, have a smoking history of at least 30 pack years, and currently smoke or have quit in the last 15 years. Then in February of 2015, Medicare began covering lung cancer screening for a very similar high-risk population with a slightly different, with a slightly different age range of 55 to 77. And I want to just give a shout out to Dr. Rizzo here as well. He testified in Washington, D.C. in order to get Medicaid to even consider covering lung cancer screening. So the Lung Association and Dr. Rizzo were very instrumental in making sure that these individuals were covered. The Affordable Care Act also required states to cover preventative services with an A or B grade for individuals who were newly enrolling in Medicaid through the Affordable Care Act's coverage expansion to 138% of the federal poverty level. As a result, in 37 states that have chosen to expand their Medicaid program under the Affordable Care Act, adults in that expansion population who fit the USP STF high-risk profile should have coverage for lung cancer screening. However, states are not required to cover the screening for the standard Medicaid program, which leaves a potential gap in coverage. The gap in coverage of lung cancer screening for standard Medicaid enrollees is significant because there's a higher proportion of Medicaid beneficiaries currently who smoke compared to individuals with private insurance, a key risk, as you heard, for lung cancer. The 5-year survival rate for lung cancer patients is also significantly lower for patients with Medicaid than lung cancer patients with other insurance, demonstrating the importance of improving early detection with the Medicaid population. With the support of the University of Texas MD Anderson Cancer Center, the American Lung Association surveyed state Medicaid fee-for-service programs between December 2018 and January 2019 to assess the current coverage of lung cancer screening in state Medicaid fee-for-service programs. This past Tuesday, we released a new issue brief, and you have that at your tables, or you were provided that information with our findings, and you're looking at a map right now of the findings. 31 Medicaid fee-for-service programs covered screening, 12 programs did not cover screening, and 7 programs did not have information available on their screening policy. Our issue brief also looks at the guidelines different states follow, as well as whether states require prior authorization for screening. Of the 31 states, Medicaid fee-for-service programs that cover screening, 13 require USP-STF criteria or follow USP-STF criteria, 13 follow Medicare criteria, and 15 follow other criteria. And you can see that in the second column there. Establishing clear eligibility criteria for lung cancer screening is important to ensure that only those who are at high risk of lung cancer obtain screening. Recent research has shown that screening is often inconsistent with evidence-based guidelines, with the number of individuals inappropriately screened for lung cancer actually exceeding the number screened according to the US STF criteria in 2015. Screening people who do not meet the high-risk criteria puts people at risk for false positives, as you heard Dr. Rizzo mention, and unnecessary invasive procedures. Additionally, 13 states require prior authorization for screening, meaning that the providers have to get a prior approval for the Medicaid program before performing the screening. Research shows that prior authorization requirements can delay patients' access to the care and even lead some patients to abandon the treatment. As you might have seen on the previous map, we are very fortunate here in Pennsylvania because our fee-for-service Medicaid program covers lung cancer screening. While our issue brief only addresses lung cancer coverage in Medicaid fee-for-service programs, all of the state's Medicaid managed care organizations also cover lung cancer screening. We should be very proud here in Pennsylvania that we are ahead of the curve as far as screening coverage is concerned. The criteria used for screening may vary across the different fee-for-service and managed care plans. Pennsylvania's fee-for-service program requires a prior authorization for screening, and prior authorization screening requirements may vary with different managed care programs. The Lung Association urges all Medicaid programs to cover lung cancer screening based on evidence-based guidelines across all fee-for-service and managed care plans, and to provide any financial or administrative barriers like copays or prior authorizations. We would like to see that they limit those because we want people to have access to these life-saving services. Medicaid plans should also promote this benefit so that more people can be screened. Also on Tuesday, and again as part of our partnership with the University of Texas MD Anderson Cancer Center, the American Lung Association released a state lung cancer screening coverage toolkit. And the toolkit includes a number of resources for public health and lung health organizations, state and local coalitions, and healthcare professionals to use in their work on lung cancer screening coverage in state Medicaid programs. And it includes things such as an issue brief on the survey, a recording of the webinar that was held this past Tuesday about lung cancer screening coverage in state Medicaid programs, an open letter from, again, our Chief Mission Officer, Dr. Rizzo, and the Chair of Thoracic Head and Neck Medical Oncology at MD Anderson in support of Medicaid coverage for lung cancer screening coverage, along with a letter from other national public health patient and provider groups in support of Medicaid coverage of lung cancer screening. We have fact sheets and an infographic about lung cancer screening coverage, information for healthcare providers, and a portal to collect stories from patients about the benefits of lung cancer screening in conjunction with a particular campaign called Saved by the Scan. And all of these resources, you can go to lung.org/lung cancer coverage and get that information. Just a little bit more about lung cancer screening coverage in private insurance plans. As mentioned earlier, most private and health insurance plans cover lung cancer screening as a preventative service following the USP-STF criteria under the Affordable Care Act. However, recent federal guidelines and regulations have facilitated the growth of what we call short-term limited duration plans and other coverage options that may reduce access to lung cancer screening and other treatments and services that are really important for lung cancer patients. Before 2018, short-term limited duration health insurance plans were intended to help individuals with a temporary gap in coverage between jobs or other life changes, and the policy would last for about 3 months and could not be renewed. Most recently, the Trump administration finalized a rule that greatly expanded the use of these plans. Policies can now last up to 364 days for up to 3 years, allowing them to compete with the comprehensive coverage that state exchanges offer through the Affordable Care Act. So we want to know, what does that mean for lung cancer coverage? So short-term plans are not required to provide coverage for basic treatments and services that individuals need, even if they're healthy now. And they don't have to cover preventative services like lung cancer screening. Furthermore, short-term plans also can discriminate against patients with pre-existing conditions. So if a patient gets screened and they find out they have lung cancer, a short-term plan could rescind their coverage based on that condition, leaving that person without any coverage options until the open enrollment period for their state's individual marketplaces comes around. So we're really concerned that these short-term plans will likely attract younger and healthier individuals, further dividing the individual marketplace risk pool. And this will probably result in a spike in the premiums that will be held for comprehensive plans that are sold in the marketplace. And the only ones that will cover the treatments and services, that'll be the only place that people can go to get those coverage for treatments and services that lung cancer patients need. So we're watching this, and we're looking at ways to make sure that we can educate individuals. But while states can set more stringent limits on the short-term plans than the federal guidelines, Pennsylvania at this point has not taken any action on those short-term plans. So that really completes my presentation on lung cancer screening coverage. And we hope that you'll have some questions that you might want to ask later on for the panel when we have Dr. Rizzo, Dr. Moritz, Dr. Robinson, and others join us. So I'm going to turn it back over to Flora.
Thank you, Deb. We are going to take another break, another 10 to 15-minute break, and when we come back, we're going to talk about the resources available through the American Lung Association. Okay, break's over. We're going to resume the program now. Deb is going to come back up to talk about the resources available through the American Lung Association. Deb?
All right, thank you, Flora. Again, I'm going to remind everyone that lung cancer is the #1 cancer killer of men and women in the United States. And awareness of early detection, including lung cancer screening, is really at a very critically low point. That is why the American Lung Association launched Lung Force in May of 2014 to unite women and men in the fight against lung cancer. And with that, we set out to achieve some very bold goals that will change the face of lung cancer in America and ultimately save lives. Through Lung Force, we are striving to increase awareness of lung cancer as the #1 cancer killer, to educate and empower patients and healthcare providers, and to raise critical funds for lung cancer research. Since the launch of Lung Force in 2014, we have made some incredible strides. We have invested $9.3 million in lung cancer research, including funding 60+ different research projects that have the potential to yield better detection and treatment methods. We've led the successful fight for a 69% increase in NIH lung cancer research funding, And we've achieved a 44% increase in women's likelihood to talk to their doctor about the lung cancer risk. We've registered 139,000 Lung Force members, enough to fill people in New York City's Madison Square Garden 6 times over. We've enrolled 1,200 plus companies and organizations in our fight, and we've jump-started a conversation about lung cancer in major media, including Self, Glamour, Good Morning America, People, and E! News. Through Lung Force, the American Lung Association is working to defeat lung cancer with our research, expos, walks, online support groups, and advocacy efforts. Lung Force is working to inspire communities to raise their voices to support lung cancer patients and research innovations that will lead to early detection and better treatments for all. This year's Lung Force is focusing media efforts on how lung cancer has impacted 1,000 plus heroes to change their perceptions of the disease and help people understand the risk. The call to action is to participate in something we call Turquoise Takeover by wearing turquoise and donating in store at CVS Pharmacy or online at lungforce.org. Our Lung Force heroes help the American Lung Association put a face to lung cancer and bring to life the impact it has on our heroes. You can see 2 of our heroes. The top, Ashley Morosky is from Pennsylvania and has done a lot of work not only here in Pennsylvania, but also in Washington, D.C. This year, National Women's Lung Health Week is May 12th through the 18th, when people and places here in Pennsylvania and across the United States turn turquoise to support women's lung health. In the Mid-Atlantic region last year, we had 14 icons turn turquoise, as did 24 office buildings. 27 proclamations were issued in all 6 states in the Mid-Atlantic region and D.C. There were 67 illuminations, and 172 Lung Force pins were sent to TV anchors across the Mid-Atlantic, dozens of whom wore turquoise on air. The American Lung Association is thankful to see so much support of Lung Force, and this year we hope that all of you might join us. Lung Force, our public awareness and fundraising initiatives, calls on all Americans to raise their voices to defeat this devastating disease. Our team, Turquoise, is now more than 108,000 voices strong and growing every day since the inception in 2014. Across the nation, we have generated 2.2 billion plus media impressions. We've engaged 350 local sponsors. We have coordinated 783 landmark illuminations, including the One World Trade Center in New York, Philadelphia Boathouse Row, and the PA Capitol. Inspired 775 anchors to turn turquoise, and we've issued 630 plus proclamations. Lung Force Expos are a great opportunity to learn more about the latest trends, resources, and research surrounding lung cancer, COPD, asthma, pulmonary fibrosis, and other lung diseases. With different tracks for patients and caregivers and healthcare professionals, this one-day event features experts from a variety of lung health-related fields presenting on current research and hot topics, an exhibitor's showcase, and a chance for patients, caregivers, and the local medical community to connect. We're going to show you a short video of our Lung Force Expos.
To really create awareness around lung cancer as the #1 cancer killer of men and women. And it was to give them the most up-to-date trends, resources, and research on a variety of lung diseases, including lung cancer, pulmonary fibrosis, chronic obstructive pulmonary disease, asthma, and many other lung diseases.
It's been a really wonderful opportunity especially for the patients, to sort of come out and sort of hear about the disease processes and the things that are out there, the things that are available to them from a treatment perspective, from an emotional support perspective. And one of the really remarkable things to me is actually just the number of people who are here. Most of the conferences that I go to are medical conferences, and so they're not really patient-specific. The fact that this is really focused towards patients is, I think, a really wonderful opportunity.
We're a long-time volunteer, local level, regional level, and ultimately at the national level as well. And what I learned right away was that being an advocate for the Lung Association, I could help many more patients than I could every 20 minutes in my office. So by helping to educate physicians and patients, helping to advocate for flow-free laws, access laws, help a lot more patients, and also helping to raise funds for research went a long way to helping patients who currently didn't have cures, and hopefully we would find more by research dollars.
It can be kind of lonely without the association. So with the association, I know there's this whole army of people out there who are experiencing the same physical as well as emotional issues.
I am an advocate, and I find that to be a really great sense of focus for me to kind of put my lung cancer as the back burner and be able to share my story and how it can benefit not just me but other people dealing with any kind of lung disease.
Okay, so hopefully that gave you a little bit of perspective of what our Lung Force Expos look like. Our next expo in this area will take place on April 23rd in Cherry Hill, New Jersey. If you don't know where that is, it's right over the bridge from Philadelphia, Pennsylvania, so we like to call it the Philadelphia area. But we hope that many of you can join us there as well. Considering this startling truth, on average, less than half of all women diagnosed with lung cancer will be alive 1 year after diagnosis, because by the time lung cancer is detected, it has spread too far. More must be done to save lives, and through collaborations, the American Lung Association is opening doors to new opportunities to defeat this terrible disease. And Dr. Rizzo mentioned this, and I'm just going to mention a little bit more about it, but through a collaboration with Stand Up to Cancer and the Longevity Foundation, the American Lung Association is supporting 2 new research awards, making this a $7 million collaboration, our organization's largest single investment in lung cancer research to date. Announced in October of 2017, the Lung Cancer Interception Dream Team and the Interception Translational Research Team are made up of innovative scientists from a variety of institutions who are carrying out collaborative research. The Lung Cancer Interception Dream Team will develop diagnostic tools such as nasal swabs, blood tests, and radiological imaging to confirm whether lung cancer abnormalities found in a chest imaging are benign lung disease or lung cancer. The Lung Cancer Interceptional Translational Research Team will develop a lung cancer interception assay to use in conjunction with low-dose CT scans based on blood-based assays that examine circulating tumor cells and circulating tumor DNA. So the work of these teams will advance efforts to detect lung cancer in its earliest forms when it is most treatable, and even has the opportunity to intercept the disease before it actually starts. Through our investment in research, the Lung Association can achieve its mission to save lives by improving lung health and preventing lung disease. The American Lung Association's Airways Clinical Research Centers, we call them ACRCs, it's a network of the largest not-for-profit network for clinical research dedicated to asthma and COPD treatment research, and it attracts some of the most and best investigators nationwide. These centers are managed by a team at Johns Hopkins University and are supported by funds that the American Lung Association raises through our events. They are all over the country, these particular centers. The Lung Association is funding more than $6.3 million for research in its 2018-2019 fiscal year, which includes 53 novel and innovative lung disease research projects, plus funding the Airways clinical research. Here are some recent examples of the proposals that we have funded. As you can see on this slide, they run the gamut from basic science to environmental interventions and self-management strategies for lung disease. The focus of our awards is consistent with our mission, again, which is to save lives by improving lung health and preventing lung disease. Okay, Better Breathers Clubs are offered throughout the country, which allow people with COPD to connect with others in person. Part of managing COPD successfully is knowing how to use your medications correctly, as well as performing breathing exercises that can help with COPD symptoms. Our new videos are using and cleaning a nebulizer, belly breathing, and pursed lip breathing are great support resources. They are also available in English and Spanish, and you can certainly find these videos at the American Lung Association's YouTube page that you can have patients use. Jen mentioned this earlier, but I'm going to talk a little bit more about, and maybe repeat a few items, but about freedom from smoking, or our ability here at the American Lung Association to help people quit smoking. It is really critical to achieving our mission. And we have, at the American Lung Association, long been a leader in this field of smoking cessation. The association is the only organization offering tobacco users a full suite of quit options. And we have in-person clinics. We have Freedom from Smoking Plus, which is primarily online, but you can use our helpline for phone support or additional support. We have the Lung Helpline, which you can call in and get solely telephonic help. We also have a self-help guide. We know that quitting tobacco is not a one-size-fits-all. Individuals can choose the option that is best for them through one of these 4 options. We cannot make anyone change a behavior. If it's not important to them or they are not ready to quit, the Lung Association knows that you have to be able to offer this program voluntarily because the person has to want to quit. Freedom from Smoking offers a systematic approach to quitting. There's a logical progression for awareness of smoking dependence to actual behavior change. We look at freedom from smoking as more of a progressive climb up the mountain with a backpack full of tools and resources, not a cold turkey quit attempt. Quit Day occurs halfway through the program in session 4. There's a strong theoretical basis for freedom from smoking. We, again, like to look at the addictive process. We know that that is based on behavior change focus. The program also supports the use of FDA-approved cessation medications. The American Lung Association in Pennsylvania has many resources available that help promote various cessation programs. And on this slide, there's examples of materials we have available from the CDC TIPS campaign. These materials promote the PA Free Quit Line. We also have a pregnancy flyer and packet that promotes the incentive program that the PA Free Quit Line offers to pregnant women. Feel free to reach out to any of us here today to place an order on these materials so that they could be shipped to your location. And we also know that you can go for more resources at the Pennsylvania Department of Health Tobacco Prevention webpage and click on Pennsylvania Free Quit Line, and you'll see additional information. The American Lung Association in Pennsylvania is proud to have a grant and work with the Pennsylvania Department of Health. This allows us to fund and provide free services in 35 counties in the Commonwealth in regards to prevention, cessation, and policy. And with this funding, we can offer cessation mini-grants to community organizations. So in addition to these cessation mini-grants, we are also able to assist in upgrading health systems organizations' electronic medical records. We want them to integrate the American Lung Association's Ask, Advise, and Refer Best Practices model to facilitate tobacco cessation among the organization's patient base. In addition to including the Ask, Advise, and Refer Best Practice model, the funds will also assist in an upgrade of the electronic medical records to identify patients who are at high risk of lung cancer and who are candidates to be referred to lung cancer screening. Again, if you're interested in any of these opportunities, particularly the mini grant opportunities, contact Caitlin Cluck or Chelsea Hildebrand. And Chelsea and Kate, do you want to just wave your arms so we know who? Okay, Kate's not in the room, but she's outside if you need to speak with her as well. Thank you, Chelsea. Lung cancer is a big problem. So what is the solution? Well, Lung Forest has 3 priorities. We want to make a cause that people care about and act on. We want to raise critical funds for lung cancer research, and we want to educate and empower patients and healthcare providers. It's people like you in the fight today who are learning and sharing your voice in your fight for lung health. Thank you for joining us in the fight against lung disease and for lung health. At this point, I am going to turn the program back to Flora.
Thank you, Deb. I have a short story here. My brothers would not appreciate me sharing this story, but they're not here, so I don't really care. I am the youngest of 3. I have 2 older brothers, and I obviously didn't experience any of this, but my father was a heavy smoker. And he didn't just smoke bad cigarettes, he smoked the worst Lucky Strikes. Do you remember those? Yeah, I see you shaking the head in the back of the room. He smoked Lucky Strikes more than a pack a day for more than 10 years. And he said to me, the day you were born, he said, I looked at you and I decided I don't want to smoke anymore, and he quit cold turkey. Now, I don't know what that says about my brothers, that he wasn't willing to quit for my 2 older brothers, but he quit for me, and I'm so grateful that I had my dad for most of my life. He did have an incident later in life. They found a spot on his lung, and they did further screening and further testing, and thank God it did not turn out to be lung cancer. So whatever it was, whatever I did the day that I was born, it stopped him. And he kicked the habit and went cold turkey and never smoked again. So I am grateful for that. I think this morning's presentation has been wonderful, great information. I love learning more about this disease. Again, through my personal stories with my son having asthma and my father being a smoker, I really am committed and I'm very passionate about raising awareness about lung cancer. There's a lot of awareness about other diseases, but I kind of think this has taken a little bit of a backseat, so I'm happy to help in any way that I can to raise awareness, raise the platform, and bring lung cancer way up there so more people know about it and know about the risks and what we can do together collectively to save lives. Okay, I'm done. We're going to take a break. Okay, our bellies are full. We're good? Everybody's good? Yeah, we're good. All right, we're going to begin the afternoon portion of this program. Welcome back to the Lung Cancer Screening Implementation Forum. I have to read this. How to create a successful and effective lung cancer screening program at your healthcare facility. Our speaker this afternoon is Dr. Troy Moritz. He is the Director of Thoracic Surgery at UPMC Pinnacle. He's not only a leader in our community and a skilled thoracic surgeon, he's also dedicated countless hours to his patients and their families to help them manage their diagnosis of lung cancer or lung disease. Dr. Moritz has also been a very visible advocate for the American Lung Association for many years now. It is my pleasure to introduce Dr. Moritz.
My name is Moritz. I work at Pinnacle. So I've worked since about 2010 as the director of the thoracic surgery program. And lung cancer screening is important to me because lung cancer screening is a way to find lung cancer earlier, and as a surgeon, then I can actually do something effective about it. And our best chance for a cure is when we find it early. That's very rewarding to find somebody in a nice early stage 1 lung cancer, resect it, and potentially cure that person and follow them for the rest of their life with additional scans and see that they do well. It's very discouraging when we find it in stage 3 and the later stages of that, or stage 4, and we can offer them much less. So lung cancer screening to me early on in my career was seen as a great way to find more early stage lung cancer. So as an advocate at Pinnacle for it, and I initiated our lung cancer screening program around 2012, and that allowed us to also develop things like a pulmonary nodule clinic and a variety of other programs around that. We've been fairly successful with lung cancer screening at Pinnacle. Our numbers were always a little bit above the national averages. And now this past year we screened about 2,000 people, which is a significant amount of screens compared to a lot of hospital programs. Now we have incorporated also at UPMC Pinnacle some of our outlying hospitals into our program, both for data registries and tracking patients as well as resource utilization. So along the way, I started a separate program outside of Pinnacle's domain, and that's kind of what I'm here to talk about today, because it's a program that has some unique challenges. So I'll disclose, I have no financial disclosures, unfortunately. I am on the board for the Mid-Atlantic and share that currently, but I'm also on the local board for the American Lung Association, and I'm happy to talk for Deb anytime she asks me to. And then I steal a lot of pictures off the internet for some of my presentations. So Fulton County, a lot of people may not be familiar with Fulton County, but it's got a small little hospital there, and it's a critical access hospital in Pennsylvania. And so we'll go over what that is. So in Pennsylvania, there's 15 federally defined critical access hospitals. And what that has to be is 24-hour care. It's got to be in an area where there's not another hospital for at least 35 miles. And usually they're tiny little hospitals, daily census of less than 25. So they are in some of the most rural areas of the state, and they often have very limited resources, limited specialists. It's difficult sometimes to provide care in those communities. So here's Fulton County. Pittsburgh's over here. We're right here in Harrisburg. State College is up here. Here is the state line, so it sits down on the Maryland state line. Its really biggest close city is Chambersburg. So if we look at Fulton County a little bit more closely, the whole county has about 14,500 people in it. There is several townships. I think there's 11 or so. They each have about 1,000 to 2,000 people scattered out throughout these different townships. But there's really only 2 towns or boroughs in the county. And McConnellsburg, which is where Fulton County Medical Center is, only has a population of about 1,000 people. And Valley High, and that's how they do spell high there for some reason, is a population of about 180 people. So it's a very land-wise large county. It's got a lot of mountains, a lot of farms, but not a lot of towns. And only one real medical center, and it's pretty small. So here's a picture of the medical center. This is the actual hospital area. This is what they call the multi-specialty clinic area that opened up maybe a year and a half ago. And so what they do is they bring in specialists from Pittsburgh, from Harrisburg, from Chambersburg to provide subspecialty care, dermatologists, GI doctors, thoracic surgeons. And this hospital usually is, they have like 1 floor. Sometimes there's 10, 15 patients in the hospital. They do have an OR. I've done a couple bronchoscopies there. But it's a hospital where a lot of stuff gets referred out. So this cardiologist friend of mine who goes out there bugged me for a couple of years to engage in Fulton County and go out there. And his sell was basically, the people are great. Everyone smokes in Fulton County. They have high radon levels, and they got lots of lung cancer. You got to come, you got to come, you got to come. And he hounded me. He's a great guy, and so I finally decided, okay, fine, sounds good. Let's figure out what we can do. So they have a need out there in Fulton County. They do have a lot of people that smoke, and I got some data I'll share in a little bit, and the radon levels are kind of high out there. So what we wanted to do was start a lung cancer screening program at Fulton County, but we also wanted to provide pulmonary nodule management. So when you screen people, you sometimes find nodules in the lung fields, and you got to have a process to deal with them because not every one of them is cancer. Usually over 90% of them are not cancer, and they just need followed up. and you got to watch and see if they grow and stuff over time. A lot of them are just benign disease. But you got to have some people that know what they're doing, looking at the scans and then following these patients. So we wanted to also establish care in the community. We didn't want to just have it satellite everything back to Harrisburg, because McConnellsburg is on the edge of Fulton County. It's about an hour and 5 minutes when I go out there, but the rest of the county is even further away. And so it's hard to get those people to get in a car and go somewhere. It's not the most wealthy county in the state either, and so a lot of people have significant transportation issues. So we set up their lung cancer screening program, and that's where resources came into play. We already had an established lung cancer screening program, and we had dedicated radiologists in our system that helped us set that up. We're part of that. We had people from marketing on our lung cancer screening committee. We had pulmonologists, we had thoracic surgeons, we had a navigator. So we had a lot of resources. We had people that helped us get it up and running initially. And so now we had this tiny little hospital that did not have a lot of resources, that wanted to provide care to a high-risk population they knew they had in their community. And so we provided that support network. Our radiology department helped their radiology department. By the way, they have one radiologist. So when he's on vacation, they use locums radiologists. So that one radiologist needed to learn some new stuff about pulmonary nodules and how we treat them, and as far as the new protocols and processes go, the updated Fleischner guidelines, which is what the radiologists use in their recommendations, but we also educated him on how we as surgeons and pulmonologists actually treat them, and what our approach to them is. So we tried to make him as beefed up as he could be. And then also with the radiology department, the CAT scanners use very, very low dose radiation. So we kind of showed them how our protocols ran as far as decreasing the radiation dose for the lung cancer screening stuff. So we were able to help them by providing people power, but also sort of our protocols that were already established. Our IT guys helped them get some stuff up on the website. So here's what happened. We started that in 2014. So in the first year, it's not 2,000 like it is here in Harrisburg, but we did 42 lung cancer screens out there, and then 15, then 18, then 16. The last year was about 50. And so it's a little bit of a shift there. And so you ask, why were 2014 and 2018 better, and then what happened in the middle? And so here's what I looked at this past year trying to figure that out. And a lot of this stuff, reading through the lung cancer guide, is stuff that you guys developed, and it's stuff that's helpful. So what you need is physician-to-physician engagement. There's a handful in Fulton County of family docs and PCPs. There's only a couple of practices in McConnellsburg. But this was all foreign and new to them. Who do you screen? Why do you screen? All that stuff. So I went out and tried to educate the community. So we did things like a grand rounds lecture. We went out to the offices and met those doctors and answered their questions. We provided them with resources in the office to help them do their job, and also educated them on the billing aspect of it so that they knew how to bill for it, and they could code for it and be reimbursed appropriately. We did physician-to-community stuff. They have a unique event out there called a Healthy Hunter Fair, which I'll go over in a second, which provided us an opportunity. And then, like I said, we used our institutional resources. We backed that up by using the people that had already gained some experience and leveraged that to help this small little hospital out there with very limited resources figure out how to get this off the ground and make it go. So physician to physician, we did the grand rounds. They had a medical staff grand rounds. We went out there in the morning and talked to their primary care docs, gave a presentation, not only on lung cancer screening, but also on pulmonary nodule management, to give them some idea of what was going to go on, let them know that I was going to be coming out there once a month, and that we had telemedicine services we could augment those visits with, and that we would be there as a resource when they found stuff, because that's a big question that the primary care docs have. Okay, now we're going to start screening. What do we do with all the stuff that we find? And so we provide that support. Went out and answered their questions, like I said, in the office, but we brought them brochures and script pads that we had developed, and I'll go over that stuff here in a second. So they're physician to community, Healthy Hunter Fair. We do stuff in our community. We have giant grocery stores that have clinic space in, like not clinic space, but like meeting space in there, and we give lectures to the community on, from my standpoint, we do women with lung cancer, we do radon and lung cancer, we do pulmonary nodules, lung cancer screening. And so we have a place or a venue that our institution's partnered with, which allows us to do a lot of community outreach and educate people. November every year I go on Good Day PA, talk about Lung Cancer Awareness Month and raise awareness about lung cancer screening. write letters to the editor, that kind of stuff. But the Healthy Hunter Fair, that was a unique one for me. So that's the shirt they give you. It's got some camo on it because it's a Healthy Hunter Fair. And what it is they got a lot of people in this rural county, and every year, hunting season kicks up and people wander out into the woods. Probably shouldn't be wandering out into the woods, and they climb up trees and do stuff, and then they drag their deer way more distance than they probably should back to their car or a truck, and so every now and then one of them keels over. So the folks out there thought it'd be a good idea to get these people in and offer them blood pressure screening, heart rate screening, do some checks, and tune them up a little bit. And any way they could, they give them a goodie bag. We went out there one year with help from the American Lung Association, and we gave free radon test kits to people since radon levels are high. But it was a good way to talk to people that had some interest in their health, talk to them about lung cancer screening, and explain it to them on a one-on-one basis as they kind of wander through the hospital and set up different booths from all kinds of different, the podiatrists to the people with the teeth prosthesis and stuff. It's kind of an interesting event because they get some people that come in from the mountains that normally don't come in from the mountains. So it was a cool venue. So shared decision-making brochures. When Medicare came out with lung cancer screening, it's a little different than a lot of other screening, and I'm sure you've kind of gone over some of that stuff, but you had to do a shared decision-making visit. And so we figured out some stuff in our system that worked, and so we shared that stuff with Fulton County. And so we had a brochure made up that basically went over who can be screened and help you calculate pack years, why you should be screened, showed them what a CAT scanner looked like, and on the back side, we had why the positives, what are the good things about screening, but we also made sure that we covered the shared decision-making and went over the false alarms and the negatives and some of the downsides to screening. And then we also went over if you quit smoking, this is the changes that occur to your body over time. And so this was very helpful for the PCPs who, some of them didn't feel comfortable having a shared decision-making visit with a patient about lung cancer screening because they didn't know all the ins and outs. And so this helps them sort of cover that from a documentation standpoint. And then scripts for lung cancer screening. Medicare, when they first started this, required extra information. You had to know pack years, were they symptomatic or not. And so we created a script in our system that covered all that, and just by filling that out, they were able to comply with all the Medicare issues. So we provided them with the scripts, which made it very easy then for them to order lung cancer screens. And then a provider in the clinic. I agreed to go out there once a month, and I still do years later. It's one of my more enjoyable days of the month. Oh, I can't say that in front of Clark because I work for him. So, but I do like it. It's an hour and 5-minute drive, and the people are very, very interesting. I find some interesting pathology out there, but they're so grateful, and it's nice to work with some of the people out there. But it also provides the PCP network out there a person to send stuff to when they find weird, unusual things on the CAT scans. Or nodules that need to be followed. We gladly follow any of their nodules for them in our sort of nodule clinic, thoracic surgery clinic we do out there. And then thanks to things like telemedicine, we're able to see patients intermittently between those visits if things can't wait for a month and we need to follow up on something in a shorter interval. So that's how we kind of went about engaging Fulton County and providing service, not just kind of telling them how to do it and then hoping that it went well. We decided to partner with them and kind of continue it. And I really realized this past year that maybe for the 3 years in the middle, we weren't continuing to do education. We got the stuff up and running. We went out, even though I was going out there on a monthly basis, it maybe wasn't enough. We needed to push harder and do more in order to get more lung cancer screens done. They're one little radiologist they have out there. When I go out there once a month, sometimes he wanders over where I'm seeing patients and he'll run a few CAT scans past me. Hey, what do you think about this? And he'll ask for follow-up and stuff. So we do continue to try to educate in that regard, but we probably weren't doing enough to educate the PCP network on the continued need for screening. So one of the things I think is also huge on that whole and then back to the providing a clinic and being out there. It's interesting being out there because I have to change how I do a lot of things because they have such limited resources out there. They do not have an oncologist that goes out there. They have no chemotherapy out there. There's no chemotherapy unit. They do not have a radiation oncologist or radiation. So everything has to leave the community and travel one direction or the other to get treated. I don't do surgery. I don't do robotic lung resections out there, and so we have to bring them out of the community for almost everything they need. They don't have a PET scanner, so if you want to upgrade into a PET scan and reevaluate a nodule, you have to make them go somewhere for that. So working them up is a bit of a challenge, especially when they don't have transportation sometimes and there's economic issues. It is somewhat difficult. And so from the start of the whole process, that's why I still go out there. Because if I didn't go out there, I feel like they would probably be like, I have a nodule, and that would be the end of it. So I do enjoy going out there, but it is a challenge working these people up. So the plan for high quality care, what do you do? What do you do with all this stuff? And that's part of the process of going out there, is providing some higher level of care, as well as navigating them. I'm sort of my own lung cancer screening, pulmonary nodule navigator out there, because I got to figure out on a social work aspect, like how to get these people the care they need. And that's really hard to do from somewhere else, looking from the outside. So going out there really helps to kind of keep things flowing. But they don't have any of that stuff. And so it's easy to start a lung cancer screening program at a university hospital or in a bigger city, if you can get your administration to go for it, because you got all those resources just sitting there. You've got oncologists eager to see patients that you've diagnosed with cancer. You've got radiation guys eager to take care of them. But in a community like this, you really don't have any of that stuff, and it's an intriguing challenge. So we provide all of that stuff as best we can, and we have a relationship with some of the other communities around there, where we send patients for oncology care, for radiation care. Some don't want to travel east. They'd prefer to go west. And so my options have become broader over the years, and where I can send them that they'll agree to. Because sometimes they're a little stubborn. Sometimes these people, it's hard to get them to go a direction that they, for some reason, don't want to go. So from a need standpoint, rural lung cancer screening, in my mind, is definitely different and more challenging than it is in a city. It was so much easier when I started our lung cancer screening program at Pinnacle than it was out here. The implementation guide's great. I didn't have that. It would have been great to have that a few years ago, instead of making everything up as we went along. You got to have some kind of a physician champion, either in the community or that's willing to support that community, and you absolutely need an organizational support. And I do feel pretty strongly about that fourth point there. Like, I think if you're in a rural area and you don't have those resources, you really got to get an institution that you're going to partner with that has all of the latest, greatest resources. I mean, they can't even do an IR biopsy in Fulton County, just a simple, old-fashioned interventional radiology biopsy. The radiologist doesn't do that, so they have to leave for that. But when we see them, we can decide whether that's the safest, best way, or is going down and doing some sort of a navigated bronchoscopy the best way. We have so many different options that we can do it the safest, best way for that patient. And so if you're going to screen people in one of these rural communities, you really need a partner institution that's sort of a center of excellence from a lung cancer standpoint, just to help be available and help to take care of those patients. The challenge with that is, if you have one partner institution with the shifting dynamics in insurance, you can't send everybody to the same place, because insurance doesn't allow you to do that. Somebody's got a different provider. So then you're almost having to partner with more than one institution, because you need more than one flow of traffic for your patient population. And the thing that, I'd like to take credit for going back out in 2018, because that's what I did. I went out and gave another grand rounds, went out and met with some of the family doctors and stuff, and really tried to re-encourage people that we were still doing lung cancer screening and to go after it some more. But there are other things that have occurred over that timeline. The Lung Association's been fantastic working with the Ad Council and having, Saved by the Scan. And so I got to feel like there's some national marketing going on at the same time. Maybe that's raising some awareness as well. In addition to getting providers to remember to do it, maybe more patients are asking for it. But whatever, the numbers have kicked up dramatically this past year, but because of efforts like that. I think anything that targets the patients and gets them to ask the question to their doc is great. Television, radio, billboards, there's other campaigns out there as well. And so why this matters, I kind of alluded to Fulton County and its differences a little bit. So if you look at Pennsylvania's statistics in 2017, smoking rates in rural areas compared to national averages in urban areas. So rural areas 23%, urban areas 14%. Lower socioeconomic areas, 32% smoking rate versus, and I think this was if you made under 25 grand a year or over 75 grand a year was the socioeconomic difference there. The rate drops down to 7.8%. And if you go to lower educational levels, meaning not graduating from high school versus graduating from college, you can see the smoking rates are really high. Well, Fulton County is a rural area with a low socioeconomic status, and it does not have a large university and does not have a large college graduation population. And so the smoking rates in Fulton County, as my cardiology friend alluded to in the beginning, are definitely higher than they are in other areas. So they have 14,500 people, but like roughly 30% of them smoke. And they also have other contributing factors such as high radon levels in a lot of the areas out there. And so they do have a lot of lung cancer. And so I'm happy to say that we're still on pace. January and February had 4 scans each. So we're kind of on pace to maybe hit the 50 mark again if this doesn't drop off. It's been fun going out there. It's been interesting going out there. And I feel like I've learned some valuable tools, or valuable lessons, I should say, about lung cancer screening programs in rural areas or areas that don't have all the resources that we have, you know, in the typical city hospital. So I'm happy to answer some questions during the Q&A on that aspect. I'm also happy to answer questions on our pulmonary nodule clinic here at UPMC Pinnacle that we run. We've gained some new experience with the smaller outlier hospitals that Pinnacle bought. Each of them was beginning a lung cancer screening or had one, or they were at various stages, and each one had different challenges, and it's been kind of interesting kind of trying to pull them all in as far as data collection and sort of the same process, the same flow, same patient registration stuff, all that, and try to make it more unified. That's helped them, and it's helped us to try to pull it all together. So I can be happy to answer questions about that stuff too. Shall we? Was that? Usually I'm way faster than I. If I talk too fast, I'm happy to repeat.
Hello. Thank you, Doctor. At this point, we are going to have the question and answer session. So I'd like for everyone to come up on the stage, please. Dr. Rizzo, Dr. Moritz, Deb Brown, and we'd like to welcome Dr. Robinson. She is the Deputy Secretary of Health Promotions, Disease Prevention for the Pennsylvania Department of Health. Welcome. Be careful. Yes, please. We don't need that today. There are no assigned seats here. You can sit wherever you want. We could play musical chairs. I'm going to run around the room like Oprah with the microphone. So if any of you have any questions, please don't trip me. I already have one bad hand. I don't need two. It would not be good. So they are here. They are ready to answer any of your questions. Does anybody have a question for any of our panel members? Do you want me to start with the question? Oh, great.
Yeah, I have a question for Dr. Moritz. So in Fulton County, what did you find was the biggest barrier from the patient standpoint? Like, what did the patients put up as a reason not to get a lung cancer screening, or was there any hesitation?
It was awareness, mostly. They didn't even know it existed. So that was a big issue, was just getting awareness. I don't get a lot of resistance when you talk to somebody who's got 30-pack years of smoking and you're having a conversation about, you know, hey, you should get a lung cancer screening. Most of them are willing to comply with that. But if there's barriers, it's often the, you know, getting transportation and all issues like that. But they don't seem to resist. Interesting, when I went out there and passed out the radon kits at their Healthy Hunter Fair, I got a couple of comments about like not wanting to put a test in their house and then send it in, because then the government would know that they had radon levels in their house, and they were afraid they were going to like get their house like eminent domained or there seems to be a slight mistrust of the federal government in Fulton County. But as far as screens, once you educate them, most people are more than happy to get a screen. Yeah, I've got a couple of Hawk nurses that work in my office that spend a lot of time calling people. We do have a higher rate of non-compliance in Fulton County, partly because, you know, people tend to move. You know, one day they're living with someone and then they've moved and they're living. So keeping track of them and finding them and getting them to come back in is a little bit of a challenge for the follow-up scan. So they'll get the scan and then they won't show up for their office appointment and stuff like that. But it's a little more challenging. My nurses do spend a little more time on that patient population.
Any other questions? Do you have a question?
I'll ask a tough one maybe. Some of the literature I've looked at, radon-related, talks about smoking-related lung cancer versus radon-related lung cancer and saying that the radon-related lung cancer may actually be a different disease. Have you heard anything about that or anything, or can you comment on why it might be a different disease, a cellular type, or et cetera? Maybe Dr. Moritz?
Yeah,
Thank you.
well, I mean, and you can jump in on this one too. So radon can cause a variety of different types of lung cancer. It's not specifically like small cell, non-small cell, and so I haven't seen that exact information that you're looking at, but it is, to the best of my knowledge, when I looked into radon from a clinical standpoint, it's a little bit all over the place as far as what kinds of cancers it can specifically cause. The connection between radon and lung cancer is if you have high radon exposure and you're a smoker, it's a 7-fold increase in your risk. It doesn't just add the risks, it multiplies them. And so as far as being a different biology, it's a different mechanism as far as the radiation damage, the DNA versus the smoking damage, but it's not, we're not able, unfortunately, and I get asked this a lot, to take somebody's cancer and test it and say, oh, this one's from smoking or this one's from radon. Now, often people want me to be able to do that. Unfortunately, we don't have that capacity.
Yeah, if you look at the cells in a smoker, the DNA has a lot higher mutational burden in it. So, and mutations in the DNA is really what makes a cell decide to become cancerous or not. So ideally, at some point, we're going to be able to, we already do have mutation targets, EGFR, ALK. Those are targets that are right now being used therapeutically. But at some point, we're going to be able to maybe say that, all right, this amount of burden of mutation is due to a radon exposure versus a cigarette exposure. As far as I know, nobody's been able to do that yet. Sounds like a great study to do. If you can isolate out the radon versus the cigarette and look at the different genetic changes that occur in that population.
Any other questions? Here I come.
Where are we with biological marking for diagnosis of lung cancer?
You go first, like I said.
So a lot of terms that get thrown around are genomics. So you're looking at genes for a marker. And there's proteomics where they look at proteins in the bloodstream or proteins that are exhaled. And what a lot of startup, excuse me, and biotech companies are trying to do, if they test a panel of proteins, 17 proteins versus 50 proteins, do they see a pattern that's going to predict or actually say that this is from a cancer cell? Right now, doing those tests is expensive. They need a large population in order to show that it's accurate. And then ultimately, they'll have to make sure that it's clinically effective and worthwhile. So a lot of it's being done. As the Lung Association, we get approached by a lot of different companies to talk about raising awareness of that kind of research because they need patients into their studies in order to get the information. But it's been going on for a number of years. An example is that the exhaled proteins that are looked at, there were articles back in the 1980s, 1990s. Recently, there's a company who's looking at it again, but our technology has changed so much, we may be able now have accurate information that will give us an answer that we've been looking for 20 or 30 years. But it's a hot field in research.
Yeah, there's a handful of things that I find fascinating about that. And we currently use one of those tests. It's a brushing in the airway. And it's not the most useful test. Occasionally it can take a patient, if you risk stratify them as high risk, and it'll come back and say they're very high risk. And the only way that becomes helpful to me is if I've taken somebody to do a bronchoscopy and I've tried to biopsy their lesion and the biopsy's non-diagnostic or maybe a little bit suspicious, and we're trying to decide what to do next. And if that comes back as, very high risk from a high risk patient, then I know I need to either just take it out surgically or I absolutely need to do another biopsy. Where if it doesn't, then I can have a different conversation about, all right, do I want to follow this up with another scan? So that helps a little bit, but the test is not good enough to like really give me much information. I mean, very seldom does it kick me from high risk to very high, and it almost never takes me from like a medium high risk down to like low risk, meaning I could just watch something. And so we do it sometimes, and it is expensive. It's like it's a couple of brushes in the airway. It's like $1,000 test. It's not something I do on everybody, but that's the only one that I found is useful currently. And we've been approached because of our nodule clinic and our lung cancer screening volume with a couple of companies out there. There's a handful of, there's a blood one, there's a variety of them. And the problem becomes, the lung cancer screening trial told us what we need to do. We need to screen people that smoke a certain amount and they're in this age group. And so when you take a blood test like that, what do you do with that then? We know if we find a nodule and how big it is and what its features are. We have algorithms and protocols, the American Thoracic Society, the NCC, and we've got professional societies, and we've got very good data that helps us with what we find on CAT scans. So then you take a blood test in there, and what do you do with it? Like, where do I go with that in the pathway of the patient? Do I do a blood test up front and then only CAT scan the people that have, a high risk? Or do I do the CAT scans, and if you have a nodule, then do I do the blood test in order to decide who I'm going to biopsy and who I'm not? And none of these tests are quite FDA approved, ready for prime time. So I've chosen not to use some of those. A, because it's labor intensive, you got to draw blood in the office and do a bunch of other stuff. And I'm not really sure what I'm going to do with that particular data. So I've chosen to use the one because I'm already making a commitment to take somebody to the operating room to do a bronch on. And I'm hoping that that information from the brushing will help me if the biopsy is not diagnostic. But yeah, I can't wait for this stuff to get better because I think it's going to be tremendously helpful. But right now, we don't know what to do with it, even if we are using the data, because we don't have protocols for it yet.
More questions?
Well, Dr. Moritz, first of all, I want to thank you for doing this. Thank you for caring about the people in Fulton County, a very low socioeconomic, low literacy area. You wouldn't have to do this. So thank you for taking care of those people up there. I personally appreciate that you would do that for a vulnerable population. My main question is going to go to Dr. Robinson. Now this takes us a little bit off track, but she's here. I mean, she doesn't do long surgery and doesn't diagnose cancer, so I have to ask her a question that is in her specialty. So, Department of Health, okay. So we know that Fulton County, Somerset County, Fayette County, they're all low socioeconomic. They all struggle. And for example, in Fulton County, I mean, there's not much employment in the area, so I would think there'd be a lot of people there, as in the other counties, that are unemployed, that don't have any, they're uninsured, don't have much of anything. So how do we, from a Department of Health perspective, and the Department of Health is very, I mean, we've been very heavy on promoting equity. Equity. We want Pennsylvanians, all Pennsylvanians, to get good health care. So how do we ensure that these folks get good health care? We don't have a lot of Dr. Moritz's around who are going to do what he's doing. How do we ensure that these folks get the care they need? Can you just address that?
That is an excellent question. First, thank you all for inviting me here to speak with you today. So I think I'm going to try to talk about it specifically from the perspective of lung cancer screening, because I think a lot of times when we talk about social determinants of health and health equity, we talk about kind of care outside of the clinical continuum. And so how do we make sure that folks have access to good food, healthy food, transportation, which are all very important. Then when we talk about lung cancer screening, sometimes we need to be a little bit more specific. And it takes a little bit more of a dedicated effort on the behalf of government agencies to say, okay, we know that these things exist, but this is a specific area where we know in communities that are affected by low socioeconomic status, high levels of unemployment, and deep poverty, they do have higher rates of smoking. And in communities that have higher rates of smoking, you're going to see higher rates of lung cancer. And so our responsibility, and I step out on a limb a lot when I say this, but our responsibility as a public health department is to still be able to offer services and prevention and treatment in those areas. And so we need to do, I would say, probably a better job in terms of partnering with our Department of Human Services to go out to these communities that are identified as high risk because they have high rates of smoking, high risk because they have high rates of lung cancer diagnoses that we're seeing at later time points, and go out to say, hey, we need to do some education about if you've been a smoker for this long, if you're over this age, you need to consider getting this lung cancer screening. You know, I think even in communities that have higher socioeconomic statuses, or STATA, I guess, people are still unaware of the fact that lung cancer screening exists. And by people, I mean patients, communities, physicians, at all levels, people are just unaware. And so if you add that to a community that may have low health literacy and high smoking rates, we need to do our part to step in, to do the education, to say, just so you know this is out there, just so you know this is where in your community you would get access to this screening, and also just so you know this would be your next step. I think to Dr. Moritz's point earlier, there's a highly mobile population in this, just because when your income is kind of insecure, you may need to move to a mobile home, you may need to move in with relatives, then you get into an apartment, then you may be in a shelter. And so I think it's important when we do screenings to make sure that we also educate these communities about what next steps would be, and then also make sure that communities have that information available. I don't know about you all in the room, but whenever my doctor tells me something, as soon as I leave the room, I forgot what they said. And I'm a doctor, so if that's what's happening, that's probably a very universal experience. And so we need to make sure that resources are available in communities. So if you did have a screen, you can say, oh, you know, I think I got a scan, and I don't remember where I was supposed to follow up or what I was supposed to do, but we need to make sure that that information is readily available as well.
Questions?
Particularly have a question, but I do have a comment on this. I mean, I'm from Department of Health Division of Cancer Prevention and Control, and I think this event was one way to try to address that, because we know that there was a lack of education in the rural areas, particularly among the primary care physicians. But it's very difficult to get those areas to come out to an event like that. So I'm really glad that they're live streaming this, and I'm hoping that some of our more rural hospitals, because I do get questions about that, is like, how do we start a lung cancer screening program, or how do we educate our primary physicians about lung cancer screening in those smaller areas like, you know, Tioga County or, you know, Clinton County, those places that are really remote. So I think this was one way to do that. We're always thinking about ways of how we can educate other physicians with the limited resources we have. The other suggestion I would make is that we would expand and maybe talk to the, you know, try to get a champion within the legislature to expand funding for all screening services, kind of like Delaware has. So they have the Screen for Life program, which covers, and Dr. Rizzo can help me here, I think prostate, colorectal, is it all those screenable cancers?
Breast.
Lung, breast,
Whereas our state funding for cancers is limited, I think, to breast and cervical. So, you know, to do something like that, to expand that pot, or expand, you know, really the different cancers that could be screened would be helpful. So those are just my takes on it.
Questions? I have a ton of questions. Is that okay if I ask questions? I'm sorry. I'm going to start with Dr. Robinson. You're just joining us and didn't have much of an opportunity to talk. So from a statewide level, where does Pennsylvania rank with the rest of the nation in terms of the number of lung cancer cases we have here in the state?
So I don't have an exact ranking for you, but I will tell you that we are, I'm going to make sure I say this the correct way, we are not doing well. So we're not ranked number one. We don't have the most cases, but we are, we have more cases than would be expected. We have a large population, but have a higher rate than average. I don't know if anyone from the department knows our ranking.
Yeah, I think, if I recall correctly, I think that we have, we might be third or fourth in the number of cases that we have. We have a little over 10,000 cases of lung cancer diagnosed every year in Pennsylvania, and that stayed pretty steady. But our mortality is actually, the death rate is actually better nationally. I think we're maybe, I'm going to say 14th or 15th, might even be better than that. So we have a lot of cases, but we're actually doing pretty well on the mortality standpoint. So the death rates have gone down. So, but I can tell you that it is the number 2 cancer in Pennsylvania as far as diagnoses are concerned, and I think it's number 1 in the number of deaths. So
Yeah.
that gives you an idea.
That does sound correct.
And is that due to the number of smokers that we have in this state? Is it because of our high levels of radon? Is it a combination of both?
I'd say it's probably a combination of both. So I think if obviously, like we talked about, if you have smoking in conjunction with radon, your risk is just so much higher. And so we have that population as well. But if you look at states that don't have as high levels of radon, their lung cancer rates aren't going to be as high. I think it's difficult to say, like we were talking about, it's difficult to know how much of cancer is radon, or how much of lung cancer is radon, and how much of it is smoking. But I think because we unfortunately have high levels of both, we're just a state and a community that's at higher risk. And so I think we just really need to do a better job of making sure that we're screening and that people are aware. We've done a really great job in terms of public health, in terms of prevention, and we talk about helping folks stop smoking, and we talk about making sure that young people don't start smoking. But one of the areas that I think we sometimes don't talk about because we're so focused on that prevention piece is preventing folks who have smoked or who do smoke from going on to develop a diagnosis of cancer. And I think that's a piece where we can really step in with screening.
And that was actually leading up to my next question. What is the state doing to make sure that we get this message out, this very important message, and that people should go and get screened if they're considered to be high risk, and prevention and getting their homes tested for radon? What is the state doing to get that message out?
So some of the radon work is done through our Department of Environmental Protection, and so I think one of the things that we could probably do better as a Department of Health is partnering with the Department of Environmental Protection to make sure that our messaging kind of dovetails on that. And then on the cancer prevention side, we have a very strong connection between our tobacco prevention and control and then our cancer prevention folks working together in the same bureau, but also thinking very kind of holistically and across the life course about all about tobacco prevention, and then moving into cancer prevention in our at-risk communities.
Before I ask anything else, does anybody else have another question before I keep going here? 'Cause I may not stop. Okay. Stop me.
Probably still too early to know the answer to this, but what about the increased use of smoking marijuana and the use of electronic cigarettes and its impact on what we might see coming on in the future?
We'll just go down the line and give our opinions. I think the biggest concern, I guess from the Lung Association standpoint, is that these are products that have only been out on the market maybe a decade. You don't really know about short-term, mid-term, or long-term effects. The biggest concern from a public health standpoint is this another generation of people who are going to learn to inhale something that they shouldn't? And is there going to be a switch at some point from vaping or using e-cigarettes going back to true tobacco products? Because there's nicotine in what they use now in the Juuls and electronic cigarettes. Nicotine's very addicting. In that middle school, high school brain, it does its worst effects as far as making the addiction so strong. So that's, I think, the big concern from American Lung Association standpoint. There are certainly carcinogens in this. We don't really know. There's so many different e-cigarettes. We don't know what's in each of them. In fact, that came up as a potential research topic, just to go out and test all these e-cigarettes and see what's in them. But I'm concerned that we're losing another generation to tobacco products that we had done such a good job over the last 30, 40 years to get down. So I'll let other people jump in.
Yeah, the FDA not regulating that product is an issue. It would be probably okay if they were regulated and we knew what was in them and it was metered as a smoking cessation tool. But even then, the problem with that is that most of those people a year later are still doing the e-cigarettes, and if you quit smoking using any other tobacco or nicotine product like gum or patches or whatever, you wind up off of that stuff. And so you basically just traded one for another addiction. You wind up staying on it. And, you know, Big Tobacco owns most of those companies anyway, so they're getting your money at the end of the day. And then the marketing to the kids is a huge problem. I know I have a couple middle schoolers and a grade schooler. Not so worried about the grade schooler, but the middle schoolers, it's there. I mean, there's kids that are getting popped at the middle school with e-cigarettes and vaping and whatever. So it's a huge problem, and I feel like they've flown under the radar a little too long, and I'm really hoping that there's crackdown from the federal government on that stuff. And as far as the marijuana issue, to date, I don't know if there is any actual science on lung cancer and marijuana that's significant. There's a handful of things I can add to that. One is, you know, most people don't smoke 20 joints back to back like a pack of cigarettes. And so it's really hard to quantify how much you've inhaled. So it's really hard to do a study and analyze cause and effect. I was at the International Association for the Study of Lung Cancer. It travels around the world, and it happened to be in Colorado a couple of years ago. And so there's literally, you know, probably 500 people in this conference room, from radiation oncologists, medical oncologists, pulmonologists, surgeons, all there about lung cancer. And the keynote address found it amusing that we were in Boulder, Colorado, where marijuana was legal. And he literally asked the audience, does anybody have any data on marijuana causing lung cancer? And nobody, raised their hand. So I don't know that there's absolute science there, but you're putting something into your lungs that's not supposed to be in there. And it's the combustibles, and it's all the hundreds of chemical elements when you burn tobacco. It's the same when you're burning marijuana leaf. You're inhaling all that stuff. It's just not good for your lungs. It's got to cause some damage, and damage is what eventually leads to DNA damage and leads to mutations that leads to cancer. So as far as being able to cite a study on that, hard to do, but common sense would say that it's an issue.
I think I would agree with everything that's been said. I know from a public health standpoint, we're taking kind of a hard hit against the electronic nicotine delivery systems, or the ENDS or JUULs, or but it's really interesting and variable about how much parents or schools or communities know about these things. And so I was out speaking at a middle school in Lancaster last year, and the event initially had been planned to be a high school event, because everyone knows like high schoolers are into things. And then someone was like, well, maybe we should do it at the middle school. And the principal of the middle school was like, well, my middle schoolers don't know what these things are. And when we opened up the event, someone held one up and just said, who knows what this is? And, I think I'm young and hip, and I was like, oh, why is he holding up this USB drive? And all these middle schoolers were like, well, that is a JUUL, and it comes in all these, and knew all this stuff. And one, obviously, I think we need to do a really good job of protecting our children, because that's our job as adults, but as kind of adults in public health, our job is really to protect communities of adolescents and young people. And so I think, like was said, that we don't know the levels of different chemicals in there. So obviously here we're talking about lung cancer today, but if we talk about just exposing your oral pharyngeal, your mouth, to all these chemicals, when we talk about oral cancers, tongue cancers, there's a lot of cancer that can happen all the way down to your lung. And so I think there's risks of that we just don't know yet, because there's so many different chemicals that are not being regulated. And I can't imagine any parent saying, well, I'm okay with my child using something that I don't know what it is. I think when we talk about it being a gateway, I think that's the other piece of it, is that kids are so used to that motion and using that, and then it's not that hard to jump from one to the other. And I think the studies have shown that it's people, as they work to use it as a smoking cessation device, don't stop using the electronic nicotine delivery system like they would a Nicorette gum or a patch, or an inhaler, where people transition off of that. And then, as it relates to marijuana in this state, we have a medical marijuana program. We get most of our calls and constituent inquiries at the Department of Health about our medical marijuana program. And there's a lot of conditions that medical marijuana can be used to treat, and that it is approved for in Pennsylvania. I think when we talk about recreational marijuana, we still don't have that data because it's been illegal in so many places for so long that when something's illegal, you technically can't study it. And I think there's a lot of stigma and misrepresentation when you ask people how much you smoke a day or how much do you smoke. People are like, well, I smoked once with a friend last year, even though if you did the clinical studies, sometimes they may have a positive, marijuana in their urine for months. And so it's hard to get a really good, accurate representation of how much someone is smoking and then what the side effects and health effects are of that. So I think for now, as a Department of Health, we're really focusing on e-cigarettes and what we can do, especially in younger populations, and then really transitioning that to kind of the population as a whole, and how we can do some education and prevention and cessation there.
And I might just add that with electronic cigarettes, it is the most widely used tobacco product now among young people. And a lot of young people who have never ever smoked a cigarette, because we are traditional tobacco product, like a cigarette, we've done such a good job of educating them how harmful they are for them, so they don't touch those products, but they think the use of electronic cigarettes is okay. And so we also find that if they use electronic cigarettes for the first time and they use that as their product, they're also more likely now to look at traditional cigarettes as a potential as well. So even though our number of young people using traditional products has decreased, we may start to see that increase as a result of the use of electronic cigarettes as well. So, lung cancer, we may see more of that somewhere down the road if that trend continues. So I think it's just really important for us to do all that we can to prevent young people from using these electronic cigarettes.
Just to dovetail off of that, my son's friend vapes, and he has all these jewels and all these flavors, and I said to him, what are you doing? And I think there is a misconception among young people, children in middle school, and especially the college scene. Vaping is huge at college campuses. They think that this is safer than cigarettes. And that's the misconception. And I tried to explain to this young man, do you know what you're breathing in? Well, no, but it has to be safer than a cigarette. How do you know that? And at some point I got to turn it off because I'm not his mother. But there's a misconception that these kids think that vaping and Juuls, that it's safer than cigarettes. So how do we get that message out to them that, as you mentioned, doctor, they're still putting chemicals into their body? How do we change the messaging and make sure that we don't now have another problem that we're getting the kids not to smoke, but now they're vaping? What do we need to do?
Well, I think part of it is saying that it's safer than a cigarette is not a really high bar. So we got to convince them that's still dangerous. Secondly, the term vaping by itself has been misconstrued. We had a discussion earlier this week among ALA leadership about, well, is vaping or e-cigarettes the way we should term a lot of this? And it's difficult to know depending on the population you talk to. The third thing is, even in the public health community, maybe not so much in this country, but worldwide, in England, they think this is a good smoking cessation device. They think it is safer than cigarettes. And a population over there is being given that information, which we don't think is really supported by the evidence that's available right now. So public health, we have to get together. FDA certainly has to be able to help us get out the studies that need to be done and restrict these things until we know for sure what's going on with them. We just think the emissions coming out of these things are unknown at this point, and who knows what we're going to have in 20, 30 years. We have a lot of work to do, no question about it.
I think part of the education process also has to be that the individuals need to know that these are considered tobacco products. Many people think that they're not. We also, the terminology, as Dr. Rizzo said, is very important because the industry uses the word vape or vaping because it doesn't sound, or people think that it's not as harmful. So we like to use the word electronic cigarette because then people know this is still a cigarette, this is still a tobacco product, and it can cause harm. So I think, as Dr. Rizzo said, we do have a lot more education to do. The American Lung Association, if you go to our website, we have materials for parents, for schools, for teenagers, trying to educate people. They're one-page fact sheets, trying to educate people about what we do know is in these products and how harmful it is. But as you heard, they're fairly new products, so we're still doing research, but there is research out there now that says not something that we would encourage young people or adults to use. They are not FDA approved or regulated at this point.
This is completely not helpful, but I find that the e-cigarettes and the vaping it fascinates me because, back in the 80s and beyond, when you'd see tobacco commercials on TV, they try to make tobacco look cool and stuff. But whenever I see somebody vape and do an e-cigarette, they're always hiding it, or they're embarrassed to be doing it anyway. There's nothing cool at all about it. It's the most ridiculous. It baffles me why kids do this. It really does.
Or you see them walking in a cloud of smoke, a cloud of vape,
Yeah.
I should say, or vapor emissions.
Hi, so, I don't know if this is working. It sounds weird from the side. Now it sounds better. Okay. So a couple years ago when CVS decided to stop selling tobacco products, I thought that was a huge win, and I kind of expected to see more companies do that, and it didn't happen. I don't know if maybe you guys know, the more technical reasonings as why that didn't happen, or if you know of any companies that maybe are going that way, or legislation towards limiting sales. I don't know.
You want to take that?
Well, we also are encouraging other pharmacies and stores to eliminate the sale of tobacco products, particularly pharmacies, because people go there to get healthy. And so right now, CVS is the only one. I believe New York State, if I remember correctly, has passed legislation, or I think they passed legislation that prohibits pharmacies from selling those particular products. And I can't remember if it's just in around New York City or if it's the entire state. But there are other states or cities looking at that now. But it's a financial decision, I believe, for a lot of these stores. The American Lung Association, our national president and CEO, has strongly encouraged other pharmacies to eliminate the tobacco products. CVS is still in existence. It didn't seem to hurt their bottom line to the point where they had to close stores. So, I think they're alive and kicking and doing a really good job. The American Lung Association partners with them on many, many activities. We're so gracious to have them as a partner.
I think it also would be helpful, CVS is not doing poorly. So I think it would be helpful for someone to do a study that published that data to say, okay, this is their before the decision, this is after the decision, they're still doing better than all of the rest of you. So maybe this is something that didn't hurt their bottom line, and something that you all could consider, seeing that this is what the marginal cost or benefit was when they went through it. Of course, you'd want the data to really shore that up. So, but I think that if that was what was shown, I think that would be helpful, because a lot of times it really is about the bottom line. And while I really don't think, especially the chain pharmacies, that's not where they're getting most of their revenue. I think some of the challenges comes, I live in Philadelphia, and where I live, there's a Rite Aid and CVS on one side, and then when you go south, you can't get to a pharmacy for I don't know how many blocks, and everything's a corner store. And the corner stores are the ones that would really be impacted by that. But if we started with our chain and retail pharmacies, eventually you'd hope that there'd be a trickle-down effect.
See a tax break.
Yeah, exactly. That'd be great.
Thanks. I was only going to comment that CVS bought Aetna, and that merger finished in October, November of last year. Their entire mission is to not be taken as a retail store. Just they want to build out healthcare, and so from their perspective, and it's filed in some of the. I spend my time reading 10Qs sometimes, but and part of that was it was absolutely contradictory to them being seen as providing good healthcare. Walgreens and Rite Aids, they're not really going there yet. They're probably a year behind, and it was part of the condition of that merger was part of that conversation around it. They're going to have to if they're going to continue to compete. They're going to try to get into further. I mean, you get the minute clinics and the clinics in Target, et cetera. Walgreens is starting to do some of that work also. I just saw an ad on TV yesterday, and so that was, now I'm going to go start reading what Walgreens is doing. So.
I think actually as a follow-up, the other piece around CVS is that with the pharmacy benefit managers and how, depending on your insurance coverage, how you have this like preference to go to certain pharmacies. So I found out that I apparently can only go to CVS from now on. And so I think as other pharmacies try to figure out how to position themselves with other insurance companies to kind of help capture a corner of the market, and then they decide, oh, we want to be about a culture of health, or we want to be all about making sure you're living your best you, and all these other slogans that they use. I think that will be part of it, because eventually consumers are going to say, well, if I have to go to this pharmacy and it's only about promoting my health, why are you still selling cigarettes? So I think that's a really good point that Mr. Aguilar brought up.
So I just wanted to help Dr. Robinson out here about what the Department of Health is doing around lung cancer. What we have done is we have funded the Lung Force Expos when they first came on the scene, because we realized there was an awareness problem in Pennsylvania. So we put some funding behind that. Currently, we're doing a low-income pilot program with Allegheny County and DEP about radon and radon testing and mitigation in low-income neighborhoods. So we have 2 areas in Allegheny County that we're piloting that in. So that is truly a public-private partnership. So we're hoping that that takes off and does really well. We have advocated to medical assistants to get lung cancer screening. So we did work with medical assistants to make sure that they covered lung cancer screening. So we did that piece. The other thing I did is I actually kind of went on a tour. I call it my nickel tour. We worked in conjunction with the tobacco contractors in Pennsylvania, and I did a presentation in each area in the state around lung cancer, what the statistics were, what the smoking statistics were, and the radon statistics, to kind of increase awareness about that. And we also supported a lung cancer education piece around radon, lung cancer screening, and smoking in northeastern Pennsylvania with the healthcare system up there, Lehigh Valley, as a matter of fact. So those are all the things that the Department of Health has done to try to raise awareness around lung cancer screening and lung cancer.
More questions?
This question's about shared decision-making. I wish I could quote it for you, but I can't. I was reading an article recently that said it was 47 or 48% of the patients who were currently enrolled in a lung cancer screening program thought that the CAT scans were preventing their lung cancer and were still smoking. So what the gist of that article was is that even though people may be checking a box that says they're doing shared decision-making, it's certainly not done equitably among providers. So do you have any suggestions as people either build on their programs or start new programs on how to do that better?
Yeah, so we struggled with this early on. One of our nearby institutions set up their lung cancer screening program differently in order to prevent that stuff from happening. You had to go to their actual clinic, and then they had a small subset of providers, mid-levels and some clinicians. So you had to go through them to get a screen. They also heavily pounded the patients with smoking cessation. And that's how they chose to set up their lung cancer screening program in a large institution with a big primary care network. And we decided to do the exact opposite because, to me, that was a barrier to being screened. It's hard enough to get people to go get a scan and then come to the office to discuss it afterward, but to make them come first, then send them for a scan, have them come back again to talk about it, I thought was a barrier. So I set our program up to eliminate as many barriers to getting screened as possible. And we do discuss smoking cessation and that stuff with people. And we have, we'll see them in the office if a PCP doesn't want to have the conversation or isn't sure if they're high risk. We'll have that. But we wanted our entire PCP network to be able to provide that, just like they could provide screening for a mammogram or anything along those lines. So we just tried to educate them and give them as many tools. We also have a video that we had created that's several minutes long with one of the pulmonologists that goes over all the pros and the cons that we have posted that's available to use. I don't think any of them use it. It's probably only been viewed once on YouTube. So it probably wasn't the most useful thing, but it was fun to make. So it's really hard. It's an education process to get, say 1,000 primary care, nurse practitioners, PAs, and docs in a network to all say the same speech at a shared decision-making visit is a near impossibility. I wish we had a better way to do it, but to do it and limit the amount of providers, to me, seemed like a barrier to getting people screened. And I just wanted to screen people and find it and take it out. Like as a surgeon, like I want to fix stuff. So that's how we set our program up. I'm not sure how you set yours up, where you're at as far as that goes.
Well, we tried a couple different techniques. I think we found that the best thing is a centralized model where our nurse navigator does the shared decision-making at the time and provides hopefully as robust information as they can to help the patient make a decision. I think the bigger question is, and there are studies that show the shared decision-making doesn't get done, and doesn't get done well if you look at across the country. It's also a barrier because some doctors don't even want to think about taking the time to do the shared decision-making, so they don't think about screening at all. Primary care doctors are under the pressure of a 5-10 minute slot with their patient, and there's other things to talk about besides lung cancer screening. I'm not saying that's right, but that's the reality of it. When Medicare put this shared decision-making in as a requirement, many of us on the panel there who were trying to make Medicare do this saw that as a way Medicare was saying, we're putting the brakes on this. We don't think this is worthwhile. We don't think it's cost-effective. We'll throw in shared decision-making, so we'll keep the number of people going for screening low. And when Thoracic Society and other organizations get together, we all feel that the shared decision-making requirement was the wrong thing to do. We're hoping that the new study I mentioned this morning, the Nelson study, more evidence that screening does make a difference in mortality will start to make these other requirements get pulled away, and the USPSTF will support it at even higher recommendation. So this depends on the platform that you have. If you're a pro screener or a anti-screener, if you have a platform you can get out your side of it, you tend to make some ripples. I'm not going to say who or where or what journal does that, but we do know there are different segments of the medical community where it's a favorite thing to do or not do.
Because it is the only screening that requires shared decision.
Absolutely. As I said before, shared decision-making is the patient and the physician talking about why we're doing this. I mean, whether I give them an antibiotic or ask them to get a flu shot, there's a reason behind it, and I should explain the pros and cons of it. Hope you didn't get that last part on tape, by the way.
I believe I heard that lung cancer was the #1 killer for men and women of all cancers. Why do you think there isn't as much awareness compared to other types of cancer?
Oh, this is a pet peeve of mine. Let me jump out on this one. So, as a young, new lung cancer surgeon, it was Lung Cancer Awareness Month is November, right? And so the color used to be white. It would follow October, breast cancer awareness, and it's pink. And you watch football games on TV, and the guys are wearing pink shoes. Like October is pink, pink, pink everywhere. The survival rates in breast cancer are much, much better. Not that you brought up this, but from lung cancer, comparing it to other cancers, lung cancer historically has not had a high survival rate. So you don't have advocates out there like you do in some other cancers. The Lung Association has done an amazing job fixing a lot of that by helping sort of redevelop lung cancer awareness. Turquoise is the color for the lung force. And you can brand that and market that a lot better and get that message out there. If a basketball player's wearing white shoes, big deal. It doesn't message very well. So there's been a lot of changes in that regard. Lung cancer awareness in females. The whole Lung Force initiative was driven for that, and I don't want to steal all your thunder, but it's been a giant pet peeve of mine my entire career that that most women don't know that lung cancer kills almost twice as many people as breast cancer, and when you tell them that, they're amazed by that. But yeah, it's an uphill battle. It's always been. It's gotten a lot better.
I also think there is a lot more hope for patients now than previously. There are many, many new drugs over the last, 5-6 years maybe. And I think that patients now are told there's hope. There's lung cancer screening where we can detect lung cancer at stage 1 instead of always, stage 4. So I really do believe hope is now a factor. And so hopefully, that message is getting out along with the additional education. We're getting that message out, and people don't look at lung cancer as something as they used to, and instead see it as something maybe, there is hope for me that I can get the treatment that I need, and I can live many, many years with my family, friends, and whomever.
Dr. Moritz, did I understand you to say that some of those materials you developed for the people in Fulton County were specifically developed for them, that population? Is that correct?
You mean the
handouts or forms or something?
Yeah, so we created a front and back flyer for lung cancer screening that had all of the pros and cons and stuff so that the PCPs wouldn't have to remember all the details.
Do you share that?
We created that at Pinnacle for our lung cancer screening program, and then we shared it with them. As far as I'm aware, our marketing department that helped us put all that stuff together would be happy to share that with anybody. Yeah, I don't understand why we wouldn't.
Okay, because it sounded like a really good tool to use.
Yeah.
And if you share it, that would be great.
A number of the hospitals, I'm sorry, on that implementation guide, a number of the hospitals have that in the resources, and that's downloadable at the lung cancer screening guide site as well.
More questions?
Hi, Sue McLean with the Tobacco Prevention Control Program at Department of Health. Can you hear me? There we go. This is just a simple question, but did you say with the lung cancer screening, you have to have quit smoking, or can you still be a smoker? And also, part 2 is, I'm just very interested in it, but it's still a little confusing to me about the screening guidelines. Is it, is it a national guidelines at this point, or are states varied in their guidelines?
Yeah, it's a national guideline, and it comes from the population that was screened in the lung cancer screening trial, although the age range was extended a little bit when the United States Preventive Task Force came out with their guidelines. So it's 78 instead of 75, I think is what the initial age range was. But 30-pack years worth of smoking, quit within the last 15. The NCCN, which is the National Comprehensive Cancer Network, adds some stuff. They do 20-pack years with an additional risk factor, and that list is fairly robust. I mean, high radon levels, head and neck cancer, there's a variety of other things that can show up in there as an additional risk factor. So sometimes we screen people that have 20-pack years, and we can document those additional risk factors. No, you don't have to quit smoking to get screened. I mean, I have people literally I've operated on twice that still smoke, and it makes me insane. But I'm not going to stop helping them. So there are some thoracic surgeons that won't operate on people unless they've quit for 30 days. I don't do that. It's so hard to quit smoking. Our colorectal surgeons don't make people stop eating fat in their diet before they take care of their colon cancer. It just doesn't make sense.
Any final questions?
But you should quit smoking.
I just want to say on a personal note, one of you made the comment, was it you, Dr. Moritz or Dr. Robinson, that women don't know that lung cancer is the #1 cancer killer? I was one of those women. I mean, I like to think I'm smarter than the average bear, but I clearly was not. I would like to applaud the American Lung Association for your efforts and the turquoise takeover and the whole effort that started a number of years ago. I was one of those anchors who started to wear turquoise to spread the message. And I didn't know. I did not know. I mean, I was under the misconception that breast cancer was killing more women than lung cancer. So kudos to you, for changing the conversation, for getting the message out, for getting the media and news organizations to take this cause on and to spread the message. Moving forward, and I'd like to just go down the line, what would you like to see happen next? We are starting to change the conversation. We are starting to raise awareness. I'm going to start with you, Deb, and we go down the line. What would you like to see happen from here?
Well, I hope through all the education that we are doing is that women and men have lung cancer as top of mind, and that we are able to educate more individuals, whether it's patients, communities, physician, healthcare communities, to start talking and having dialogue about lung cancer screening as well.
I think from a public health standpoint, I would just say continue to reach out to us. You know, we have great programs, we've got great people, we're ready to work, but we're not the only ones doing the work. So if you're hearing things that are working or that aren't working, let us know so that we can tailor our approach to make sure that we're approaching these issues in communities in a way that makes sense. Because it's not always a one-size-fits-all, and how we address something in Fulton County is different than how we address something in Center County versus Fayette or Philadelphia, and so we want to make sure that we're reaching people everywhere, and so reach out to us and let us know what we can do.
Yeah, I'd like to see the federal government fund lung cancer at the rates that it did breast cancer for so many decades. I mean, that's why there's such great survival in that disease now. That kind of funding would go a long way, both in the research front, the advocacy front, the state level. It would be really helpful. You got to fund it, make it happen.
Yeah, I think just continuing the patient education, physician education, and hopefully with the new research information, we'll have recommendations that are more robust, hurdles taken away from us as far as shared decision making, so it'll be more appropriate for physicians to say, go get the screening done because it's the right thing to do.
All right, well, thank you, everyone, for participating. Thank you to our panel members. And Deb, I believe you have some closing statements. Thank you.
I'm pretty loud, so I probably could have gone with that. Thanks, Flora. Well, I'll start you up there. Oh, okay. Well, first of all, I also, if I can just put one more thing, what I want people to know is one of the most important things is that anyone can get lung cancer, and hopefully you heard that loud and clear today. You don't have to have, certain risk factors. Anyone can get lung cancer. So I also want to take a moment just to say thank you to Flora. She's done a great job of keeping us on time today and introducing everyone. So a round of applause for her, and thank you. Appreciate it. So I also want to say thank you to all of the participants, the panelists and attendees today. We had some terrific discussion, particularly here on the panel. Thank you also to the Pennsylvania Department of Health. We appreciate all of your support, not only with lung cancer, but all of the work that you do. So in an effort to gather your feedback and to further assist you and your organizations in the future, as well as the American Lung Association, we are asking you to complete a short survey based on the information that we presented today. And your feedback is really important, as I said, to help us with future events and assist your organization with the implementation of this guide. So prior to leaving today, we hope that you'll be able to complete a survey using the following bit.ly link, which is up here. And this link will also be emailed to everyone who registered electronically. So I'd like to just say on behalf of the American Lung Association, it has been a pleasure and an honor to have you at our forum today. We hope that you leave with a sense of urgency and action to help us defeat lung cancer. Thank you all, and safe travels.